Lynn Marshall. That's what I go. That's what I go by is Lynn. That's my nickname. My formal name is Bobby. I've been in EMS for right at 34 years.
Wow.
I've served as a field paramedic, supervisor. I've worked on offshore oil rigs and ships. I'm a certified flight medic as well. And I've been an educator for the good part of about 25 years. So I really enjoy the teaching aspect of it. It's really encouraging to myself to see new people getting into the field. Not only place some of those that's getting out, but it shows that there's still some attractiveness out there to this field, because if you're in it for any time at all, you do go through periods of discouragement and feeling, sometimes it's burnout, sometimes it's just feeling despondent. But to see new people to come into the field, or to people that even it's been at it a while to decide to step up and increase their education, it's encouraging to to a lot of us veterans. Now, I'm also glad to see that the advanced EMT is starting to make a comeback, if you will. It used to be called, or something similar. We used to have what they would call EMT, then the EMT intermediate, and then the paramedic. And the intermediate kind of phased out there for a while. Very rarely did you see any EMT intermediates. But now, with the advent of the advanced EMT coming back, it came back really out of necessity. The paramedic shortage, for one thing, and some areas just might not want to go to the full paramedic level, but they have the need for advanced care in a lot of areas. It's like the old EMT intermediates. They were pretty much, we used to call them like they're the ones that handle the trauma. You go out, you get your IV fluids, the first step into an advanced airway, and if you had to make an interceptor route, that's what they were there for. The how you're going to be utilized in your areas, I'm not sure how all of the local areas are going to start using advanced EMTs. I know on the Gulf Coast, they're starting to have not only the paramedic trucks, but the AEMT trucks as well. And I think that is some valuable experience. You've heard the saying that some people go from zero to hero, and they'll go to EMT school straight through to paramedic and come out and be a licensed paramedic. But and I've seen some be successful with that, and I'm not saying that's a bad way to go. However, there's no substitute for experience, and you really don't want that first flash pulmonary edema patient, the first one you ever see, is to be when you're the paramedic. It's good to be able to see that handled by somebody else, or to be in on a few of those as well. That's why I think if you decide to go into paramedic, or if this is your step toward paramedic, that this experience will be invaluable to you, because it's a good stepping stone, and I think it should be a requirement before people go to paramedic school. So I'm going to everybody walk on each other. Let's see. Mark, tell me what made you decide to come back and get your AEMT.
I'm doing a renewal. I let it lapse, and I just miss being able to do the little more advanced skills.
Okay.
I've been to P school. I think a lot of times the paramedic is I don't want to say overrated position, but it's not utilized to its full extent. Mm-hmm. I mean, the number of actual paramedic calls that we run are way outnumbered by the number of advanced EMT calls we run.
Okay.
So I think this is just a good middle ground.
Yeah. All right. Annie, what about you?
I got my basic a year ago on December the 3rd. EMS runs, or medical runs heavy in my family. It's been a childhood dream. I just had kids at a young age, so I had to start a little later. I do want to take my advanced and go through it, and then work a while, and then go for my paramedic.
Okay. Is it Ronald? I'm sorry. RW?
Rocky.
I wrote it down wrong. I'm sorry. All right, tell me a little bit
That's all
about
right.
yourself.
All right. Well, I've been in EMS 20 years now. Been EMT basic for 18 years. Started out with our community agency. We've been in service for 25 years now. And we started out volunteer with 2 ambulances, or excuse me, 1 ambulance, and kind of moved up to 2, still volunteer. And about 5 years ago, just the shortage of volunteers and licensed personnel, we moved to a paid service. So now we're operating 4 ambulances in this community, and we're a paid service, and we have a huge shortage of volunteers. I'm actually the EMS chief over it, and we are an ALS level 1 service. And with the shortage of paramedics that we're having now, I felt it's best for me to just go ahead and get at least my advanced license at this point, so I can further help with the department, when I have call outs and so forth. And this is not my only job as well. I actually own a security company and been in business for that for 18 years.
All right. Well, absolutely.
Multi-task.
All right, Rob Roy,
Present.
tell us about yourself a little bit.
All right. So I've been in EMS for about 15 years. A little bit, well, yeah, around about 15. And, as far as the civilian side, I was always just an EMT basic, but most of my career I've also been in the military as a medic. So it was kind of more like basic and then some. Started this company, ARES, after my last deployment, and I was in the process of going through paramedic school, but COVID decided that just wasn't going to be in the cards for me. So I've backed up. I'm kind of serving a dual role in this class. I'm a student as well as just making sure that things go right. So what better way to make sure my programs are working than to take them myself and see how it goes. So that's kind of where I'm at with it. AEMT, I should have done this a long time ago. In fact, I've been kicking my own ass for a while now for not having done this years ago, but better late than never. And yeah, here we are.
I'll be calling on you to guide me through some of this technological challenges with this new program too. So we have discussed earlier that this is a learning curve for a lot of us. This is the first time that I've used this format to teach a class. I've used others in the past. I really like it. So it's a no judgment zone for the technological issues we're all going to learn with. Okay, I see one DD. Who is that?
That's Donnie.
Oh, Donnie. Oh. Okay, I think we'll let him join us. Okay. All right. I hope you can all see my PowerPoint lecture up on the front there. We're starting off with Chapter 1, EMS Systems. A lot of this is review, and it does seem redundant for you, and I definitely don't want to bore you to death with it. However, it is very important. Now, I've always been in the EMS 34 years. You can't help but feel a little passion about it. So, I started off watching sirens go up and down the road back in, and I hate to say this, but it's actually back in the 70s. And this television, it was so wild, man. It was a family event. We lived up in East Tennessee, and you'd hear a siren coming, and my grandmother would come and get us, and we'd all run to the porch, and the whole family watch them go down, got them go up the road. And a few minutes later, my grandpa said, "Hey, watch them. They'll come back this way, going back to the hospital." And he said, if it's real bad, they'll have and we called them, we didn't say sirens. In East Tennessee, it's called siren. So we would watch that. And I remember my little brother coming, waking me up. Hey, an ambulance is coming. So we'd run to the porch. And then this TV show, Emergency, that you've probably heard some of the older people talk about, Squad 51. Then that started coming on, and I was hooked. That's what I used to play growing up. I even had an Emergency Squad 51 Halloween costume, and so it really stuck to me. And I even got to meet those guys. I've got an autographed picture on the wall. I met those guys a few years ago, and the story that they told, it's like, hey, if you've ever watched that show, every show or that you see was based on real calls they went on, because they actually rode with the LA County Fire Department. And this goes along with like what our lecture talks about tonight. But they rode along with the LA County Fire Department, and every scene or show was a call. And they actually sat through the training at that time. They didn't have to take the training or qualify or get licensed with it, but they actually sat through the paramedic course at that time, which was about 4.5 months long. And they saw a need for starting EMS systems. It was new to the area. They wanted, a lot of people were dying in the streets, and they had to find a way to get the hospital to the patient, so to speak. And that was one of them that done it. So I used to watch that show, and I used to tell people, hey, I want to do that growing up. And it became reality. So EMS systems. Now, a lot of this, like I said, is going to be review for you, but this is what the structure is based from. So if you can, how many of you were you able to read any of your stuff before tonight? Material, looked over it. If you didn't, no big deal. But that's what we're talking about with the fundamentals. Sometimes reading ahead for the class of what to expect, write down questions. If you're able to do so to read ahead of time, it does help sometimes as far as bringing up questions that we may need to answer that doesn't hit on in the PowerPoints, because there are stuff in the PowerPoints, that's not in the PowerPoints, that may be needed in the class or needed in the real life scenarios. So we're going to talk, as this goes on, some of the medical legal issues in these 2 chapters tonight: safety and well-being, the medical legal aspects of it. And the safety and well-being, it can be boring. How many of us just recently, if you work for a paid service, just had to go through these yearly training put on by OSHA and required as far as the medical legal aspects, safety and well-being, in the PPE, the training and stuff that we're getting right now in the advent of all of this OSHA stuff due to COVID. We've really been bombarded with it. EMS started off as plainly just pre-hospital organizations. And then it's kind of like, well, when somebody gets something good, other people want to steal their glory. It's kind of like, well, now the hospital wants to be EMS, and it is in the chain, but I kind of felt like I had something to from in a little bit, and I'm saying this jokingly. But I worked for an EMS service in Slidell, Louisiana for a while, and the hospital that we worked for, they got EMS week shirts, and the ambulance people didn't. So it's kind of like, wow, everybody's kind of getting a piece of our pie. We'll get into a little bit of the history of EMS. I'm not going to read the textbook to you, but basically what got it started: roles and responsibilities and professionalism. That's going to be a big one, because a lot of EMS classes, if you remember your EMT class, they probably didn't spend a lot of time on responsibility, the history, legal aspects. Even though that's a whole lot's not put into that could be one of the biggest impacts on your career or even your personal life. So we are going to talk about that a little bit deeper than maybe what you've had before, because that's kind of a baby of mine. Research. Every time you do, I'm not sure with what kind of formats that y'all may have to report your runs and stuff, what kind of reports that you write. Just about everybody now in the transport side is going to electronic reports, but upload into a data system. And a lot of the information they use for research, statistics, is pulled out of your report. Drop-down boxes. You see a lot more drop-down boxes in some of these electronic reports. And please, if you're not using those or needs me to elaborate more about what that's about, please speak up and say something about it. But the drop-down boxes is what they get research from that goes into these data systems. So when they see it, like the trauma boxes, it'll ask, were they restrained? If they were, was it a lap and shoulder belt? Did the airbag deploy? That goes into the National Highway Safety Transportation statistics. They had it was a wreck. high impact speed. It was a trauma. Seatbelts were not used on this many patients. So that's kind of the way those drop down box work. I'm going to brag about Mississippi a little bit. I remember years ago, before we had the electronic reports, we had to turn over the back of the written report and actually do a dot to dot format. And it went into like a Scantron, and it would say like the recorded vital signs. Was it below 90? We would have to circle a dot. I mean, it took longer to do that than it did the actual report. Well, when we went to the electronic versions, that helped out a lot because it automatically extracted that information. If they didn't have it this past year because of the COVID situation, but they used to have a trauma symposium on the coast down there, and it was supported by University of South Alabama, the 6 coastal counties of Mississippi, and people came there from all across the country. You know, UAB in Birmingham. I've seen people from Johns Hopkins came, and they talked about that a lot of the nation's data retrieving information was modeled after Mississippi's format all those years ago, when it's developed into pretty much, I can write a report, and I've worked for different systems, even the flight systems. Just about the same information is in every one of them. It may be rearranged a little bit or formatted differently, but the same information is about in just every one of these charts. And that's where it came from, that very basic program we started off years ago. So that data collection, it comes from your reports, and it evidence-based decision making is something you're going to start hearing about that when you get into more of the advanced classes. The National Association of EMTs is we're a training center for. The PHLS classes and things like that are all evidence-based decisions, treatment modalities, and it's not all based, it's not on theory like it used to be. It's like, hey, if we do this, then this should happen. It's coming down to where, like, hey, this worked, this is what we're going to do. This didn't work, we're not doing this. For example, if you've been in this longer than 5 years, you remember 5, 6, 7 years ago, we spine boarded everybody. They looked at you wrong, we spine boarded them. They sneezed, we spine boarded them. So what have they discovered based on that evidence that, hey, spine boards are not used all that much now, where they shouldn't be? It's called the Selective Spinal Precautions, is what a lot of services call them. But based on the evidence, we're like, hey, they really didn't make a difference. What they did do was cause extreme comfort, tissue breakdown, and pain that was unnecessary to somebody. So that was based on evidence, and it all comes from charting and reports. Public health emergencies, we see one going on right now, and you're not going to find this in your textbooks. I was trying to research some things earlier, and the history that we're seeing now, you know, it's being written right now how to deal with this COVID. But we will, 5, 10 years from now, maybe they'll be teaching some different classes in the programs. But right now, we're still learning from it. So, but some of the stuff that we've learned in the past as far as public health emergencies, like you remember the SARS that came out, maybe the Ebola that we went around and trained people for. Simple things that have been learned from disaster response and natural disasters as well as man-made. That all goes along with what we've learned in the past. The key components of the system we'll talk about in detail a little bit longer, but they all affect the way you do your job, as far as the call being made, the information taken, given to the ambulance or the responding agencies, and how it affects you. And we'll discuss our roles a little bit better, because when you get into roles and responsibilities, now that you're taking the advanced EMT program, I'm going to make a disclaimer right now that says you're going to learn stuff on the national scope, which means some places will be able to do all of the material and techniques in the advanced EMT program, and other areas may be limited. And so you always have to learn your scope in your area and of what your local protocols and guidelines are. So and that goes along with, like, in Louisiana, I can do more as a paramedic than I can in Mississippi, because and I've had to become familiar with what those roles and responsibilities are in that state, and you'll have to do it in the areas that you work as well. Now, some of you said you may work for different companies, different agencies. Each one of them may have a different medical director, and they can limit your practice. They can't expand it beyond what the scope is, but they can limit what you do. So we're going to talk about roles and responsibilities a little bit more later. This is a team. It's teamwork. It's not something that you can do as an individual. You're going to have to rely on other people in this field at each level, whether it be whether you are. Some of you said you are a first responder. Some of you said you are a transport agency that responds. Some of you do both. So you can tell what you'll be able to tell and share how beneficial these other responding agencies are. Like if you're on a transport ambulance, and you get to a let's say you're an advanced EMT or you're an EMT, and you get to a location where there's a first responder there, and they may be well intentioned and mean well, but you see that they didn't do the proper thing. How would you handle that? You jump on them and tear them down, then they may not want to be part of this team anymore. You get out there at 3 in the morning and need lifting help, they might tell you, hey, we're not coming, because of the way they was treated last. So it is a team. It goes all the way from the first person that lays hands on the patient until the definitive care is reached inside the hospital. State and local law, it's difficult from the way this class is structured for me to be able to relay and find information as far as what each individual location is able to do. And that is going to be the responsibility of you to look up your local EMS laws, scope of practice in that area, and local guidelines with your agency, because it does vary. I know around New Orleans, each parish just about has a different type of protocol and guidelines. So when they cross over to the other areas, they may be licensed, may be able to function different, but it's important you know that those roles, or you can get in trouble for it. State licensed or certified. Now, this is an NREMT, National Register of EMT class. It provides a certification. Certification means, hey, they successfully completed this information that was given to them, and they have shown competence. That doesn't give you permission to practice. A license issued by a state or the certificate issued by the state, that's what's giving you permission to practice in that area. That's the difference between the two. So more discussion about that later. What's the difference between a license and a certificate? A lot of times it's just wording, but a governmental agency that allows you to practice, that is, they're actually licensing you. Okay, the different levels of NREMT. Now, we used to call them first responders, and the training that varied, it varied greatly among the early first responders. Sometimes they would go take a class that wasn't really based on anything. I've seen them very loosely thrown together, and then they were not accredited, and they had no guidelines. So the National Registry a few years ago started accepting in the first responder program, and they call them emergency medical responders, or EMRs. I don't like the term EMT basic or basic EMT. I never used it when that was what it was considered. They are if you carry an EMT license, you are not a basic, you are an EMT. It's an emergency medical technician. You're in this class hoping to get your advanced EMT and then the paramedic. So it's no longer called a basic EMT or an EMT paramedic. These are the titles that the NMT recognizes. So some states that don't recognize National Registry, they may have different criteria or different levels. So, and I've seen them advertised from like EMT 1 through 4 in certain states, and I don't know how that they actually break that down. EMRs, we want the first people to get there to have some type of training that not all of them do. A lot of times, I've seen fire department personnel, police officers get there that have no training, and they're supposed to be stabilizing the scene and get some type of order. But we hear a lot of hollering and screaming on the radio saying, "Hey, we need help here now," and it doesn't help anything. So it's great if the first responders, when I say first responders, the first people that are there, whether it be police, fire, if they're in perhaps a private gated area that has a security system, it would be great if they did have the entry level of training. It's provide initial care at first, become an assistant. There's an old saying that they use in PHTLS, and it talks about that the first hand that touches the patient usually determines their outcome. So each one of these is important, is encouraged. Now the EMTs, basic life support training, you start using airway adjuncts, assist with certain medications, and access to an AED. So that's one of the biggest differences between the EMR and the EMT according to the National Registry guidelines. The advanced EMT, that's what we're looking at now. IV therapy, administration of certain drugs and medications, and you will learn some advanced airway management in this class. However, local guidelines may determine whether or not you can use those or not. We'll have a skill station at the end of the program, a boot camp. And when we get to the advanced airway stuff, I plan on doing some demonstrations for you that you can actually watch here on the program, and just kind of give you some guidelines of what to expect later on. If you're working now with an ALS agency and where they intubate, and you're there as a student or as an employee who's able to watch, observe, sometimes seeing what they have to go through with, or knowing why or the how, the other part just becomes naturally. So paramedics, endotracheal intubation, that is the standard. That's the gold standard as far as securing an airway directly into the airway. It isolates the airway, whereas a lot of the supraglottic airways that we'll talk about later do not. Pharmacology, good varied selection of different drugs that we use. Cardiac monitoring, it's not the automatic defibrillators, but we have to be able to interpret the EKG rhythms and determine what treatment modalities is indicated. And of course, there's some advanced skills of treatment that we use, decompressing chests, things like that. That's at the paramedic level. And what you're doing with the advanced EMT, you're taking a step toward that. You're learning the baseline grounds for getting that done. 2009 was the last time that the National Highway Safety Transportation Act looked at and reviewed standards. Some of these standards are just now making it to the textbooks because it takes a lot of patience, but a lot of these things don't trickle down very fast to get to the practicality of it. So the textbook, I encourage you to read the textbook. It is on your, you can either read it, or I was listening earlier to some of the audio readings of the textbook chapters, and I don't know, it's the same monotone voice, so your voice may be better than that to read it yourself or whatever, but it is there available for you to read it. Maybe you can log into it, read it while you're going somewhere traveling, but reading the textbook, it is important because there is information on there that's not going to be on the slides. Now I heard someone say earlier that they do emergency calls as well as non-emergency calls. And in the transport business, unless you work for a specific municipality, you're going to have probably both. There's not a whole lot of municipal transport services. A lot of times they have contracted private services to do their work for them. Most private services that I've worked for, they were contracted to cities or counties or areas of a state to do their 911 calls for them. And along with that, they did the non-emergency and transport services as well. television shows just the good calls, just the bad things. It seems like I can't hardly watch like Station 19 in some of these calls, because every call it seems they're doing a chest decompression or cutting a throat or something like that. And we all know that, you know, I've decompressed several chests before, but I can count on one hand the times I've actually had to put a needle in somebody's throat. But of course, television shows it the same way. Most of our calls, most of them, as one of the students said earlier, is really supportive care a lot of times. A couple of shifts ago, I did like 2 emergencies, and the other 4 times was mainly just really supportive care. They couldn't use a car. They just needed some help getting to the hospital. And if you let those kind get to you, then you're not going to make it long in this field. But that's what a lot of them are. So discussions that'll be upcoming will be, of course, scene size up, patient assessment, packaging, treating the patient, and whether or not EMS may be a career. Now, I started off doing this in 1986. I actually remember my first ambulance call was October 4th, 1986, and most of y'all probably weren't born. But I was getting into it temporarily, and like I said, it's become a career, but it has been something rewarding because I've got to do a little bit of everything. But scene size up, when does that actually start?
The time of the call.
The time you get the call, time to call happens, scene size up. You're wondering, hey, when I get that information, what am I going to do with it? What's going on? Well, they're way out. They're 30 miles from a hospital. Got multiple patients. That right there tells you what you might need to think about getting. But that starts at when the call comes in, or when you get that call information. Another term you may want to get used to is situational awareness. That actually starts at that time. We're going to have all kinds of environments to work in. People that get into this because, they don't like the cold or the wind or the rain. They don't want their hair messed up. They're going to be very disappointed, because we have to work in all types of environments, dangerous environments. Like we said earlier, where you live at, there's shootings every day. You know, you're going to have a shooting when you go to work. You know that's going to happen. And the scene issue, as far as it may become unsafe once you get there. It doesn't always have to be like well, I'm not going into an unsafe scene. Have you ever had to abandon a scene? I have. I'm not too proud to run. I'll get out of there if I don't feel right. I've had to do it before. Patient assessment, that's the foundation of any call we go to. It's when does that patient assessment start? When you put your hands on them, it really happens when you walk in the house across the room. You should be able to start making an assessment. 2 nights ago, I had a guy that was modeled severe flash pulmonary edema. My patient assessment, well, really before I walked in the house, I could hear him. And then when I saw him, he looked sick. Skin was modeled. Right then, I know I've got oxygenation and circulation issues. Guy needs help right away. See, the family, when you got a bad call like that, the family can either help or they can really hinder you. So that could be that's part of the scene as well. But is your patient oxygenated? What medications are you going to need? Is the complaint different than what you see? How many times have we seen that the complaint is different than what they see? Are you short of breath? No, I'm not short of breath, but yet you're breathing 40 times a minute. Do you always know what's wrong with a patient?
No.
I don't, but I can usually tell you what ain't right. So that's another way we need to start thinking. It's like, what's wrong with them? I'm not quite sure. What's not right? Well, this. Is it something I can fix? Yeah. Okay, we'll fix it. So that's what we got to try to start looking at. It's not so much as what's wrong, but what ain't right. As far as the treatment, that's going to vary on what we need. You start back, is the ABCs messed up? If it is, well, we got to fix them. That directs our treatment right away. And then we can go from there. Are they going to need medications? Bleeding. Have any of you taken a PHLS class lately? It's no longer ABC, but it's XABC as far as controlling extenuating hemorrhage initially. So that's something we'll learn a little later. But delivering babies, people in emotional crisis, family that's in emotional crisis, packaging. The talked about, used to everybody got a backboard, C-collar, CID, but it's not the case anymore. It's not always that way, but there's other ways to package people. One of the biggest things, and I think it goes along with packaging, that I see people miss a whole lot lately is blankets. You know, you pick up a bad trauma scene, a trauma patient, and you get them on the stretcher, straps, backboard, and hey, they're not even covered up. And once the body cools, blood will not even clot anymore. And EMS as a career, yeah, you can make your own career out of it. I'm positive proof of that. But in order for that to happen, you got to take care of yourself, and you got to learn how to cope with certain job stressors, which there's a bunch of them. And I know right now, I know myself, feel really overwhelmed with a lot of the stuff that's going on, and I see a lot of my coworkers that are like that. And we'll get into that discussion a little bit better when we talk about getting into well-being and stuff. So the requirements from state to state is going to vary. Now, most of them require entry-level high school diploma or equivalent, immunizations. In some places, that is a must, and of course, a valid driver's license. Now, the EMT requirements from state to state are not as stringent, because I actually have known people that had a record that were able to get an EMT license, but they would not be able to be granted an enhanced level license. A lot of the states require a background check, drug screening, BLS CPR class. That should be, or you should already have that before you go into this class, because it's not part of it, but you're going to need it. State recognized AMT course, and then recognized written and practical certifications. A lot of states just recognize the National Registry. They take the National Registry's test, their practical exams, and that's what they use in order to be able to license their people. So that's why it's good to be in a National Registry state. And if you looked at the NREMT website lately, I encourage you to go in and look at it later when you get a chance. But what they're forming now is a compact agreement between a lot of states. If you're licensed in one, like times of disasters or mutual aid, that you're automatically licensed in another. I know nurses already have that in a lot of places, and EMS is trying to get toward that as well. So you got to be able to do the job psychologically, physically. This job is very physically demanding. I'm so glad now they have a lot of the power lifting stretchers, automatic stretchers that lift. Very fortunate if you have those. Some places still have basically ones that we got to pick up yourself and put in. But this job is very physically demanding. Psychologically, it takes a lot out of you psychologically as well. Might not want to admit it, but it is very demanding. Not everybody can do this. I've seen people quit after one bad call sometimes. So if anybody ever has a question or anything, feel free to stop me and stuff like that. So the state, Mississippi, Louisiana, I know they use the National Registry to cover their state certification. Now, is Alabama full National Registry state? I know they
Yes.
I thought they were. I know years ago when I first started doing this, they were not. They had their own certification process that they had at that time. Your certification is good for 2 years. You don't have to wait till that last few months, as a lot of people do, to start getting your certifications ready for your next recertification. Once you get your certification in the mail or online, once it says you're certified, you can start that next day doing your CEUs and getting your registration ready to go for the next time. And I used to be a program director, and I'd always get that person, man, they need to give you a grace period. And I said, you got a 2-year grace period every time. So there's a lot of things out there now to keep you help keep you certified, as far as like the NAEMT, the National Association of EMTs, great organization to join. They always have things online that you can do for that, and programs like ARES, who you're taking this class through. We're starting to add a lot more CEUs and recertification classes, so those opportunities are available.
I want to actually add to that real quick, just so you all know, you're going to get CEU hours for this while you're going through the course. So if any of you are up for renewal this year, this will cover it. You don't have to worry about doing your CEs on top of this class.
Certainly will. The ADA, American with Disabilities Act, is this is a program that came out years ago, and it's there for reasons. Back in the day, people could just disqualify you, not want to hire you because they just didn't like the way you look, or well, they got something wrong with them, they got a problem, too bad, you just can't do it. But this protects people with disabilities from being denied access to programs provided by the state and local government. It prohibits employers from failing to provide full and equal employment to the disabled, and it protects you if you have a disability from seeking gainful employment. Now, it doesn't. If you're not able to lift but 5 pounds, then you certainly won't be able to work on a truck. That kind of goes with the fit for duty tests and things like that for it. But this is pretty much a blanket statement. But just because someone has an issue, like we've had to, the hearing impaired, I've seen paramedics or EMTs turned away for that, 20, 30 years ago because, well, how are you going to use a stethoscope? But anyway, this is the American Disability Act that's out there, and it's for protection of people with disabilities. Origins of EMS, volunteer ambulances in the World War II. This is where a lot of this started at. It's like, hey, they didn't even have to have many times training in the civilian world, but in the volunteer, in the ambulances in WW2, they had some training, maybe how to pick somebody up. Tourniquets was a big thing. Cauterizing, things like that. So we've come a long way since that advent. Helicopter. If you've ever seen the TV show MASH, that's where Mobile Army Surgical Hospital. That's where that mnemonic comes from. But they use helicopters a lot to get injured people from the field into the hospitals quickly, so they can receive care. That's carried over to the civilian world. We see it all around. There's actually, I don't have the exact stat with me now. There's actually, when I was a flight medic, the company that I work for, some of the statistics that they would show is that there are actually too many helicopters in some areas. Now, back in the day, we would run like in Hattiesburg, we might run 20 calls a month. Now they're doing probably 30 calls a month, which is not a whole much difference, but it's because every direction from there, you have another helicopter service. So, and they're cutting in on each other, but they're getting to be, as far as population is concerned, they're saying that there's too many medical helicopters now. The advances in trauma care, they learned from war casualties, not only in the Korean and Vietnam conflicts, but over in the Middle East areas now. They are learning a lot in the way they treat people, and it carries over into the civilian world as well. A lot of military medics will come to you, they're able to do a lot more stuff or have a different modality of treatment, and it's like, hey, you hadn't made it to us yet, so you can't really do it in the civilian world, but it's interesting to hear them talking to learn from. As I talked about earlier, is the late 1970s is when people started really putting trained personnel on ambulances. In fact, the CEO at the company that I work for now just wrote a book called Raising the Star, and he was the first director of EMS for the state of Mississippi. He wrote a book about it, and the reason being was he had some family, he knew some family that was not able to be moved to a larger hospital because there was not an ambulance available, no trained personnel, and they had to watch him bleed to death because there was no way to get him anywhere. The funeral homes a lot of times operated ambulances, but in his situation, they weren't available because they were actually handling a funeral. So, and they got money for that, not the trauma transport. So that's how it got started in Mississippi as far as getting the law started here. And it's back in the 70s. And he, like I said, the book, he's got the book out now, so you can read about all that information. So 1966 was when it started, as far as like, hey, we got to get together on this stuff. We got to actually make this. This is a thing. People are dying out in the streets. They're dying out in the rural areas. This is at that time it was considered modern, but there was no regulations and everything on how to handle this. And that's when they got together with the Department of Transportation, started developing EMS programs. And back when I was talking about the TV show Emergency, that's when actually some of the first ALS units started to happen. So it's the 1970s, not that long ago actually, but that's really about how long this field has been around. And I've heard forever that it's a new field, but I guess it still is compared to a lot of other areas. ALS foods. Now we had an overabundance there for a while. We had at one time, not so. I say 10 years ago, we probably had too many paramedics. And they said, well, with all the paramedics that we got going on, it may be a little longer than 10. But then I talked about earlier, the intermediate was a classification of a pre-hospital provider, and it kind of went away. And it kind of went away at this time. It says we got enough paramedics, we don't need the middle level EMT anymore. And that's one reason that it went away. So, but we find us now getting into a situation that wasn't planned. It wasn't on any of the charts. We're getting a shortage of paramedics again, and we've seen the need to go back to, hey, we need that middle level provider back. It's kind of pertinent that we get them back. Hopefully they'll go on to be paramedics, but if not, it's a great level to stabilize and get people to defensive care as well. So I told you earlier that licensing is a state level function. It allows you to be able to function in that area. The national level really doesn't give you permission to do anything, but it sets a level of standard that most others do follow. And the local level guidelines, local area protocols, guidelines, it's what's set by your agency or your region, pretty much day to day what you're able to do and what you're not able to do. Like I said, they can limit your status. They can limit that, but they can't add to it. All right, let's have does any of y'all know any you said somebody had been around for a while that said you know some first responders and things like that. You need to go if you live in a small apartment. There's always that guy that's been around forever but never got any training, but they let him stay around. Anybody familiar with anybody like that? I've seen them at some of the departments and stuff before. They mean well and everything, but there again, they never got updated in the training. So we have a lot of people out there that are certified CPR, first aid training. Sometimes they'll show up on scenes, be very well intentioned, but sometimes they can get in your way. But they started a couple years ago, like hands-only CPR for people that were reluctant to do mouth-to-mouth, to get that intimate with somebody. Compression-only CPR does time and oxygenate until they can get some airway in place or definitive care. But these programs are still in place for not only people that want to respond, but people that actually have access to a lot of vulnerable populations. For example, teachers, babysitters, coaches. There for a while, I was doing a babysitter class. I'd be willing to do that again if I had a need for it. But it's a babysitter class. It emphasized, infant first aid, infant CPR, just some things like that. That if you were looking for a babysitter, someone to watch your kids, it'd be a good little resume thing. I would pick somebody that had that type of training more so than somebody that wouldn't. So a lot of times you can go on these places like some of these camps with special needs kids. There'll be people there that are trained to deal with them, and you can actually, take heed of their advice on how to deal with certain people with different developmental levels, because we don't hit on that real deep in this program. So don't be, you please use them as a resource. The AEDs, they're not going to tell you to shock on something that doesn't need to be shocked. That's why most of the time you don't hook them up until somebody's in distress, but they detect life-threatening arrhythmias and deliver an appropriate level shock. You really don't need any special training on these, even though we do teach it and train people on them. It kind of relieves some of your anxiety, but they're designed for somebody to walk up to them in the mall or an airport to open them up, and it tells you what to do. So all of the pre-hospital training now, the AED is taught from the EMR all the way up through all levels on how to use this. Like I said, it does relieve your anxiety, and what I've witnessed is people that are, if I'm actually doing a formal training class, people are nervous about doing the AED, but as someone out in the mall, the airport, like a lot of times they'll pick it up with confidence and go at it. But it's really not to be intimidating at all. So the EMRs, law enforcement officers, park rangers, firefighters that are not EMTs or paramedics, this is a great program for them to get into, because it helps people to recognize the issue, provide just, pretty much straight to the task of emergency life-saving procedures until the EMTs, advanced EMTs, can get there. They're buying some time for you to be able to do that, because there's not an ambulance on every corner. There's not a staffed first response truck on every corner. But the fire departments are usually there sometimes first, law enforcement officers, park rangers. They need to really have this kind of training, and this is there for them. It's what it's really meant to be. So Good Samaritans, a lot of time training first aid and CPR, they show up at a scene, and they can be very helpful at times, but I've also seen them interfere. So you kind of have to decide how you're going to deal with that, how you can be constructive with them. They can interfere with operations, what's going on. They can get themselves in danger. It's kind of like I remember when CPR went to CAB away from ABC, and the people that took CPR classes 10 years ago, they thought you were crazy and hollering and screaming at you. They don't even know how to do it right. They don't even know how to do it right. Those people are interfering. If they're interfering with my scene, I want them removed. I'll ask the police to remove them. I want to get them away. If they're helpful, even if it's just hold a bag for me or something, then I'll let them do that. But the scene is bad enough without somebody interfering. Myself, I want to be able to control the scene as much as possible. If there's somebody there that I can control that's interfering with it, they've got to go. EMTs, it's an average class of about 150 hours. Some states require more because some states actually allow the EMTs to do more. This is a basic knowledge, but it's a great foundation. This is where you start laying the foundation, because ABC can only be dealt with so many ways. This is where you learn that good foundation to build from and go up from there. I recommend being an EMT for 6 months or a year before you try to advance. For a few reasons. You can actually watch somebody else do these calls or assist in these type of calls. You don't want, like I said earlier, flash pulmonary edema. The first time you see that, you don't want it to be when you're in the back of the truck as an advanced EMT or the paramedic. It's good to work for a little while to get some experience under your belt to be able to see that, to learn from. So the advanced EMTs, you've got more knowledge than the EMT. You should be able to make a much deeper assessment and know a little bit about what not's right with that patient a little bit more. And you've got some more tools now to use, more treatment modalities. So you'll be able to, this is the first step in being able to do more for them and to be able to help them. The advanced EMT class, it is significantly longer, of course. You're doing advanced level treatment now, and these classes range from 200 to 400 hours, minimum, depending on where you are. Some of them in some areas do endotracheal intubation, whereas others use the King Airways. Some people still use the combi tube, which I do not like, but you're taking the next step up for that. You're supposed to be a sound EMT before you should really even think about becoming an advanced EMT. Paramedic classes, again, vary. A lot of places are becoming it's an associate degree, but 1,000 to 1,300 hours, wide range of ALS skills depending on where you are. In some states, I got to remember that I can't do, like in the state of Louisiana, as an FPC, I can do a chest tube. In the state of Mississippi, I cannot. So I've got to be familiar with those areas, so they do vary from state to state. The EMS is looking to expand to take in more roles as time goes on. We'll talk about the mobile community paramedic program or mobile medical community program that's going to be coming up. And the reason that is because a lot of patients don't need emergency care all the time, but they don't need to really go to the hospital for. So who's going to fill that need? That might be something that we look at doing in the future. Some places are already starting to do that. So, and it's going to be expected to evolve, to take on more roles. It seems like every time something does happen, it does fall on the hands of EMS, and I just don't see where it's going to get any break from it. However, right now we do have a time of, we're having a tough time holding on to people because nobody saw the Corona COVID on the scenario. So things that we got to look for the look in the future. We got to build bridges to strengthen partnerships, relationship with agencies, organizations, different individuals. For example, if a Medicare patient right now, if they leave the hospital, let's say this is an example, but let's say that they're treated for like pyelonephritis or a kidney infection. They leave the hospital. If they come back, I want to say it's like within 28 days, the hospital don't get to collect money for that first time because they didn't correct it. So maybe this patient just needs some lab work and a round of antibiotics they didn't have to come back to the ER for. That's where we see the potential of community paramedicine probably coming into play with that. They could go out, do on-scene labs, prescribe antibiotics for this patient. The hospital could pay the ambulance service that fee because I'm sure it wouldn't be as much as them not being able to collect for that first hospitalization. That's just some things that's on the outlook for that may happen. So it may increase like that. But first, right now, we got to get her feet back under herself the way we are. But I'm excited about if that does happen. So people now can actually, it's easy access to get a hold of EVMS, 911 in most areas. I don't know of many areas that don't have it now. They may be some somewhere, but 911 and enhanced 911 is a 3-digit number to get you into to help. Years ago, I dispatched when I was in paramedic school years ago, and I've seen that people actually would call and said, "Hey, I'm calling for my mama who wanted me to call because she didn't think she could call." I said, "Okay," so she dialed 10 numbers instead of 3. That makes a whole lot of sense. But it happened. A lot of places do the trained dispatchers, emergency medical dispatchers. They're trained to give information and advice over the phone or instructions over the phone, while at the same time getting the ambulance en route. The way that that's supposed to work is they have different criteria, like, well, this patient, you don't need to run lights and sirens to this patient based on the information that I get. And they only can give you what they do get. I mean, I've been several times to where somebody had fallen, so they go priority 2 or no lights or sirens. And the reason, when you get there, you find out the reason they fell, that their heart had stopped. But they can only go with what that's given to them. The enhanced, that's where the caller's name, address, Fire department location shows up on the screen. Now, that's from land-based phones, however, which we're actually getting away from. Calls made by cell phones now a lot of times bounce off the nearest tower that it came from, so they may need to ask you more pertinent information to help locate you. For example, I've seen people in Jackson County, Mississippi, make a 911 call, and it bounced off a tower somewhere north of Mobile, and it looked like the call was in Alabama. So, and then they would route the call to Alabama. So it was, it can be screwed up like that, and it's something they just hadn't caught up with yet. So that's some things that you may be required to explain when you get on the call. Like, hey, why did it take y'all so long? Or I had to get transferred through 4 or 5 different people. What's up with that? So, and you'll be able to tell them, hey, this is why that works, because you are going to be the scapegoat. You are going to be the one that catches all the flack from the system's errors because you're there and everybody else is not. So that's one of the reasons that stuff happens. The EMD is just what we were just talking about. They go through a series of questions when they ask them. If you've never seen the way this works, it's kind of like if they get a call, hey, the first thing is, where do you need the ambulance? Not what is your address, because your address may be ABC and you need the ambulance over at XYZ. So they should say, where do you need the ambulance? Then they start asking questions like, hey, does the patient have chest pain? How old are they? And automatically, if they're having chest pain and it's over 35, that call will flag red and means immediate dispatch. And other times they may say, well, they're 3 years old. All right, they'll start asking more questions and ask more questions before a response determinate's made. But that's kind of the way the EMD is supposed to work. Now, I know I'm not familiar with the way. I hadn't worked in Louisiana in a while, but I'm not familiar with if they require all people that answer medical 911 calls to be EMD. But I know the state of Mississippi does. And that is a good thing. I know we all like to beat on dispatch and talk about dispatch some. And like I said, I've been on both sides of the fence, and there is issues on both sides that's just beyond the control of the person doing the operation. So a lot of the information we receive in EMS is from the National Fire Protection Association. They actually control a lot of what we do. According to the NFPA, 40%.
Mayor, welcome to the class. Try to mute your mic. Sorry.
Who was that? Oh.
I didn't mean to walk over you, Bobby. I was just saying, have Merrick just got into the classroom. I was just letting him know to mute.
Okay.
Or if you can mute him.
I did it too. Okay. 40% of fire departments provide BLS care. 16% provide ALS care, and 39% don't provide any emergency services at all. They don't provide any type of emergency services at all. What does that say? Not all places have first responders respond to help you out. But we're getting to see more and more that are trying to do so. A lot of the old timers in EMS or fire departments, they really don't like it because they'll tell you, hey, before we got into EMS, we didn't do anything. But EMS calls have become about 80% of the calls among a lot of the fire departments now. In some areas, EMS is part of the department. Sometimes they're the police department, but most places are independent private agency that's contracted to the area to do that. Cell phones, pardon me, my dogs are raising hell in the background. there's a lot of new technology out there, like we talked about earlier. GPS units, cell phones are linked to them. Sometimes you can ping and track phones based on where they are. Uh, and it's changing rapidly, and sometimes it's hard to keep up with. And that's where hopefully you have in services and things like that in your area that you work in, where you keep up with it. But I really don't understand how a lot of these new radios and stuff work in some of the places that we go, and that's why I'll color code my buttons. If I need to talk to this person, I'll call that one, or I'll use that one. Okay, different equipment you're going to be getting used to now. Checking equipment before you get on duty is very important. You want to make sure, like, you're going to be looking at IV bags and IV fluids, things like that now. Make sure that they're packaged intact, as we'll go over later, but make sure that this stuff is working. It's the same thing. It's what you're going to need, that you have enough. One thing that I lay hands on every shift is to make sure I got a pediatric BVM. And why do I do that? Because I've been caught without one. So make sure that your equipment is there, that it's working properly. Said, hey, well, I trust the person that left off with me, and it's like, well, I hope they check their truck as well. What if this ambulance goes to somebody in your family and they don't have a piece of equipment that they need? That's what's going to happen if you don't check it. So some of these questions are redundant, and it's kind of like, hey, it's a given, but sometimes you're going to have to drive. I'm sure a lot of you may do a lot of the driving now, if you especially work with ALS, a full ALS truck. In some areas, they're putting up the AEMT trucks to where you might have an EMT that's doing most of the driving for you. But having a good driver's record has a lot to do with you having employment. Making sure your truck gets there, the fluids, everything is intact. Make sure you have enough gas. Yep, that happens. I've seen an ambulance run out of gas before. That's just inexcusable if you ask me. Equipment and supplies, you're going to run out of them. Sometimes we run out of, I've seen to where we ran out of certain types of IV catheters, certain types of fluid. We've run out of them before. So I think it's kind of, some people say, well, I don't get paid until 7 o'clock, so I don't start checking stuff out till 7 o'clock. But it's just kind of goes back to saying, hey, what if this ambulance is called to treat one of my family members and I don't have what they need? That's being empathetic. That's kind of like what you got to look for. So human resources, if you work for a private company or a municipality or somebody that you're paid for, you should have a human resource department. They're there hopefully as a employee representative, employee advocate, instead of somebody to look for punishment. They're actually supposed to be the liaison between you and the company if anything goes wrong. So the talked about scope of practice before. EMS agenda for future is going to have systems that we're not even sure of. It's going to be developed yet. But what you're doing right now is laying that foundation. That's what's going to be so important later on. We'll talk about medical direction and medical control. When you're out there, you're working under a physician. Now, these guys and gals, they some of them are out of touch. Some of them are there to collect a check and probably don't know who their providers are. A lot of providers have never met their medical director. That's sad, but it does happen. I love to see one that's interactive, that's interested in what's going on, that actually does run reviews, run reports, does a CQI process to be able to tell what's going on. But the physician director, he's authorizing what you may do up to a certain point. And it's between standing orders and protocols. That's what your offline medical director creates. He or she, the difference between online medical direction and offline is the simple that online is a physician that is available for you to talk to immediately, whether it be on the phone, over the radio, or somebody can relay that information to you. Offline is indirect. They're the ones that that responsible for issuing you your medical control or allowing you to work under their license. They do the standing orders, they write protocols. Then a standing order is something that you can do without having to call. That is something that you should be expected to do without having to call, or it's up to you to get it done. The training protocols in most states, you've got the EMS legislation in place that gives the scope. Medical directors and the EMS people can get together and develop a set of protocols of what they would like to be able to do, and that has to be approved with the by the state EMS agency. I've wrote protocols for some of the coastal services before, and me and the medical director would get together. We'd look at national standards, what's worked for other areas, what other areas are doing, and if we get any feedback on that. And then we'll make our own format, those to our needs, what we'd like to do, and we present it to the state office. They either approve or disapprove or tell you we got to change. And once they issue them, then those standing orders and protocols become what you work under. But that's pretty much the way that runs, just narrowed up. So some hospitals treat certain things better than others, and then you have other ones that just don't treat anything above basic everyday run-of-the-mill ailments that don't require definitive care. So I'm sure in your area, I know around Mobile, you got a couple of STEMI centers, you got a big trauma center. Over in Louisiana, they have the Learn Network. Now, when I worked in Louisiana, before I did it mainly as a flight medic that responded from out of Mississippi to Louisiana, and they really didn't coordinate us much if we were coming from out of state, but in state. And if there's anybody on there from Louisiana, please correct me if you need to. But the way I understand it, the Learn program works is the Louisiana Emergency Response Network. Is like if you have an activation or say like a heart attack or trauma or stroke, that is the line that you call, and they tell you, hey, your destination is this hospital. Because they have like a rotating board on who's full, who's not, who can handle this trauma, who can handle this heart attack. And within that area, they give you an actual location that you should be transported to. I kind of like that in a way because you don't get a lot of the feedback of why are you coming here? Why are you coming here? We're the closest facility. And we've all probably experienced that feedback. So you should be very familiar in your area who handles these activations. And these are pretty much standard activations across the country. A STEMI, heart attack, trauma, and stroke. Those are time-sensitive injuries that require definitive care immediately, and it doesn't need to be transferred around from one place to the other. That's something we should be upfront about and know where these people go. The mobile integrated healthcare I touched on a little bit earlier, but this actually come out when they had the Affordable Care Act that come out a few years ago, and it was there again to people that have limited resources, is to keep people from having to go back to the hospital for things that they could be treated outside the hospital for. But right now, there are some pioneer programs across the country. They're mainly in the Northwest and out West as far as the community paramedics. And it's eventually, I think, going to catch on with the advent of all of this influx that the hospitals are getting. And some insurances, and I know Medicare will not, like I said, will not pay for a visit if that patient has to return within like 28 to 30 days of something that they've just been released for. We talked about quality control. Now, I've participated in CQI programs before, and it's not meant to be as punishment. A lot of time the medical director will have designees out there that will look at reports and evaluate them. It's like, hey, here's, I see you varied from the protocol a little bit. Why is that? Or, hey, man, you did a great job on this call, but I was wondering why. And when I used it before, it was mainly to fill in some gaps that may have been just left out or not documented, or I would find out it's not supposed to be used as punitive or finding punishment issues, but like, hey, why didn't you do this? Well, I wasn't sure, or I just didn't know. Then you have a training issue. Punishment should only be used if you have somebody that's doing something willfully wrong. Otherwise, it should be coaching or a time to train, things like that with it. Sometimes it can be seen as like, hey, I've noticed you've missed or you've had to go to a secondary airway on the last couple of intubations, I want you to come in and let's do some training on intubations. And let's see what's going on with that. That's kind of what that we would use it for. Now, if somebody just can't intubate, then they're not really something that needs to be trained. They might be a risk issue at that point. But that's mainly what CQI and the quality is there for. A skill that you don't use a lot. Say, for example, you don't decompress that much, or as an AMT, maybe you don't put down that many advanced airways, and that skill will deteriorate over time. That's why regular training sessions need to be in place to keep you abreast of that, to keep you up to date on it. So errors happen, and for this, an old saying I use sometimes is, God may forgive you, however, the system may not. So some of the biggest times when errors actually happen is transferring patient information. You can, we've all heard these horror stories of having to go to court and case studies and things like that. I've been called into court sometimes years later on different situations, and one of them was, hey, why did the doctor write down different information than what you provide in your report? I'm not sure. And they said, well, here's what he said, and here's what you say. Why is that? And I said, well, it's probably because when I was turning the patient over in the room, there was total chaos. Nobody was listening to me. So that's it's hard to tell what he wrote down or who he heard it from or who repeated something wrong that I said. So that's one of the biggest times that it happens, is transferring that type of patient. That's why you always document, hey, and this is the way I do it every time, and I learned this the hard way, is patient report given to Dr. X or Mary Sims RN. I put that in my narrative. So driving to the scene. I mean, we all probably know people that's wrecked and got killed going to scenes or got in bad accidents. And in an emergency vehicle, and it, most of the time they're going to try to find somebody to find you liable for that. So that's when it happens. Patient drops is another big one that happens. Why is that? Well, the patient, we lifted up too high and they turned over, or we hit something in their driveway and they turned over. But lifting and moving is another big time when patient errors can happen. So how do we eliminate these errors? It's something you got to think about. You can't plan for all of them, but it's something you got to think about what can happen. Why am I doing it this way? So some of the biggest things the way these happen is, rule-based failure. Hey, I didn't follow the rules. I didn't put all the straps on the patient, so he fell off when we turned over. Knowledge-based, hey, I just wasn't sure. Was the information given to you correctly, or I just didn't understand it. Skill-based, hey, I hadn't done this in a long time. The stair chair, I hate this old stair chair. I hadn't used it in a long time. Well, what happened? Well, I got the patient in it and it collapsed. So any of those can lead to that. Sure, we're never in a hurry. We're never expected to hurry up through one call and get to another. That never happens to us. But unfortunately, we live in this environment that so much of it is expected of us. Sometimes I don't know why it is, but a lot of the houses I go into, it seems like they have no light bulb in the room where the patient's at, or it's so dim in there I can't see. And there have been, and because I hadn't experienced any, but as a former safety and risk coordinator, I have seen to where a patient was given, if you think of verapamil, it's in a blue and white bottle, Benadryl's in a blue and white bottle, and they received the wrong drug because it was poorly lit. Is that excusable? It's not. Get them to where you can see. So those things happen like that. The reason we talk about them is they've happened in the past. We try to prevent things from happening like that again. So one of the biggest things, I want you to learn this from this day forward to wherever you go, even if you go to medical school. Why am I doing this? Be able to say why. That is one of my philosophies that I've used ever since I've got into this, and a very involved medical director told me this 30 years ago. He said, just be able to tell me why. Say why you did it or why you didn't do it. If you can't say why, you probably don't need to be doing it. And that involves with that can involve your personal life too, really. But be able to say why you're doing this. Cheat sheets. Uh, a Broslow tape. If you're familiar with the Broslow tape, that is a form of a cheat sheet. It's something that kind of helps you to look at and verify. We used to think, oh, I'm going to memorize the pediatric neonate dose of an epi infusion in my head. That's crazy to do it in your head because you forget things. I can't tell you what I had for breakfast this morning. So these cheat sheets, they're very helpful. These you'll see like the Glasgow Coma Scale cheat sheet, things like that. Use them because I guarantee if it ever got called into court, they say, hey, how did you figure this up? Well, I figured it up from memory. No, yeah, okay. Then they'll probably give you some type of exercise. Say, I use my cheat sheet right here. I use this little card for the Glasgow Coma Scale. That's going to save you. It really is. So use downtime to refresh skills and stuff like that. Setting on posts. I know, man, sometimes I'll run 10 calls in 12 hours and sometimes I'll do one. And periodically I do read my protocol again in my procedure guide because I've learned the hard way sometimes, hey, this is stuff that you're going to mess up on or you're going to get, it's going to get monotonous or something I hadn't used in a long time. Like mixing up a Pitocin infusion for somebody with postpartum hemorrhage. You know how many times I've done that in my EMS career? 0. But I read it. I want to be familiar with it because I don't want it to be that time that I need it that I can't remember how to do it. Discuss troublesome calls with your partner or your supervisor. Now we're going to talk about some self-help stuff later on, but don't let these calls build up. After every call, and I didn't learn this till late in my career. And when I work with a new person now, when I say this, they look at me like, man, what is your problem? But I ask them after every call, I'll say, do you have any issues with that call? And at first they're like, what are you talking about? What are you talking about? I said, I mean, anything we need to discuss. I mean, and when you give them a couple examples, oh, well, why did you do this? Or so-and-so done this. Why did you do it this way? Okay, well, here's why. I had a girl the other night that could not explain why I was hurrying her so bad. I was hurrying her so bad. And it's kind of like, hey, I told her later, I said, hey, these flash pulmonary edema patients, they'll die quick. And I didn't want her to do it in front of her husband. Just get him out of the truck. So that's why, I explained it to her. She said, oh, okay. But talk about these calls to your partners or your supervisors, things like that. Don't let them build up on it. Use these people as a resource. So information systems, this is kind of like what we talked about earlier, the electronic patient care reports. These track information, they store it, they allow you to document it. The drop down boxes, and a lot of them have kind of safeguards in place that won't let you advance to the next section unless you do complete it, and it kind of saves you from things later on that you might forget. Like for example, I'll put in GCS and it won't let me go to the next one unless I put on there if it's affected by any outside source, or if it is a normal variant of this patient. This is normal for this patient. They might have a 4 or 4.3.4. Is that normal? No. But if you put on there, this is their baseline, then it makes it, well, this is no alarm for this patient. So that's how that works. And the data is retrieved from these logs, examining this type of patient, or what, let's say like if you get a certain amount of patients that have, you got a lot of cardiac arrest in this area, for example, it might help them say, oh, we need to buy a Lucas device. Or that's kind of the way that some places use this type of information. I know we don't like to talk about money. People ask how much is this going to cost? But the bottom line is if the money doesn't come in, it can't go out. And right now we're not getting a lot of reimbursement on some things now because of the red tape buildup. A lot of places down that have processed this stuff. So some companies are actually struggling right now. So that goes along with documentation. I know sometimes we say, hey, it's the business office's responsibility to get this stuff done. However, if you stop and think about it, I know I have had trouble with a medical bill before because somebody just didn't do their job on the other end and code it right or document it right, or could have said something in there that would have made it apply. So just think about that for for future use. These are some of the ways that people do get paid: grants, fundraisers, like for volunteers. A lot of volunteers, man. I know it has got some volunteers on here, and the way they get their medical supplies is they pretty much give them away. They got to work, have fundraisers, somehow get different the supplies that come in, and they use it. Probably not be able to bill for it. Some places are able to swap out with the paid services. Hey, I used 5 4 before. Okay, well here you go, 5 back, because they're going to bill for them, whereas you can't. So just remember, the money has to come in before it goes out. The education system, I've seen it where people, well, they've been a paramedic for 15 years. Let's see if they can be an instructor. That don't always apply to just everybody. You don't want to pass it on old habits. So there's a lot more screening that goes into it now. Like the AMT instructors, we got to be approved through the state EMS office. Most training programs now are going to what they call the Committee on Accreditation of Educational Programs for Emergency Medical Services, and the Commission on Accredited of Allied Healthcare Programs. If you see those acronyms out to the side, if you take any online classes or anything like that, make sure it has those by it, or a registry may not accept it as being approved CEUs. But before I've seen classes where people just talk about something for an hour and get up there and say, well, I read chapter 9 of the paramedic book to my shift, and they want to get credit for it. I was like, really? I mean, credit needs to be verified and substantiated. So remember those acronyms right there, and make sure your classes come from those organizations. All NAEMT classes and all the classes that you see put up on this format are approved by these agencies. So that's one big reason Robert got out to start this company, is to have some dedicated and reputable information given out. So before we put it up here, we make sure that it's already taken care of. ALS instructors and directors must hold a 4-year degree. That's what it is in most areas. As EMT, in AMT, you're still required to attend a certain number of hours each couple of years. But like I said, don't wait till the last minute to get it done. A lot of the college paramedic programs are through the colleges, and but if you will get credit for these classes like the advanced EMT before getting in there. Some of them have entry level like interviews, screening processes, but if you're already an advanced EMT, you will get priority over someone that is not. Health fairs, public education, you may be asked to participate in some of those later, and people are going to come in talk to you about things like, hey, as far as car wrecks and stuff, hey, what can you tell me about helmet laws in this state? Or do helmets really work? What about car seats? Do they work? And the big one right now everybody's getting is, what about these vaccinations? Still a lot of unanswered questions out there about that. But people see you as the expert in these fields. They think, man, you're the one out there with the lights and the sirens. You know everything. What can you tell me about this? So a lot of these agencies they participate in public health places. EMS research, drop-down boxes is what that goes for. Some places have actually participated in research that's done to provide future training. Back in the day in New Orleans, when we would go to work, we would have to decide, well, they would let us know, well, today Tulane residents are in the emergency room at Charity. We will not be using mass trousers, but we will be using lactated ringers. So they're going to see how those work. The next day it might be LSU, and they're like, we're going to use saline and mass trousers. So every couple of weeks we would switch back and forth, and were actually experimenting and learning on how these things work. The head doctor for that at that time was Dr. Norman McSwain, who was the pioneer for PHTLS, pre-hospital trauma life support. If you've never taken that class, I highly recommend you do so. But that's where a lot of that stuff comes from as far as playing the roles in research. Specialty care centers, not all hospitals can handle all types of patients we talked about before. I think Louisiana has some better resources than what we have in Mississippi, Alabama. I don't know if you're along the Gulf Coast, the coast part down there, you've got USA, but like say like for example in South Mississippi, sick children, nobody wants to take care of them. They either have to go to Mobile, Jackson, or New Orleans. We're in a and hopefully air services are available. If not, you got a long ride, a very stressful ride. STEMI centers, places like for heart attacks, doing a 12 lead in the field, discovered that they got a STEMI, transmitting it. A lot of times these patients will bypass the ER, go straight to the cath lab. Stroke, same way you should know the stroke areas in your place. They can get there within that window. They can start TPA on this stroke, dissolve the clot, and then transfer them to definitive care later. But knowing where these specialty centers are, and people, unless there's a case of airway compromise, should be transported directly to these training centers. If you have the ability of air transport that will save a lot of time, that's great. I have a app on my phone where I can watch like helicopters and airplanes all over the area. And every time I look at it, and especially Louisiana, it seems like I'm always seeing Acadian Air Med up and flying. Coastal Alabama, I see it down there. They've got AeroCare, Southlight, different agencies down there, and then Mississippi has several agencies as well. But it seems like Acadian is always flying somewhere over the state of Louisiana. So some places are more fortunate than others as far as having these available. But know what's available in your area. You got to be responsible for that. Interfacility transfers, I used to hate them, now I like them. It's because it's a great opportunity to learn something from. Say, for example, how many of you can tell me what aortic stenosis sounds like? If you've heard it before, you may be able to. Where I learned what it sounded like was when I did an interfacility transfer. I looked down on the patient's chart and it said they had aortic stenosis, and I listened to it. And from that point on, I was always able to detect it or pick it up. So you can actually learn from these calls. And these patients a lot of times don't require any more than just monitoring. Sometimes they do call for some intervention in between them. A lot of patients that just require IV transfers, hey, they may send the EMT truck for that to save a paramedic truck for probably the 911 calls. So what's important, interfacility transports, that they're still very important. You got to know what's going on with a patient, just like you would from the scene. You need to know their medical history, their allergies, what's going on with them, what's been done, because I've had those patients go bad in between the facilities. I had to know what to do with them. So sometimes you may have to have a nurse or a respiratory therapist or sometimes somebody else ride with you, because by COBRA law, they have to provide the same level of treatment they're receiving in the ER during transport. That's what's supposed to happen. They may downgrade it to like, well, they can go with just an IV and some O2 and, no harm done. But technically they're supposed to do that. That's why they may send somebody else with them. If you ever feel uncomfortable with one of these transports or feel like they're putting something on you that is above your scope or something you're not familiar with, you need to speak up then, because if it happens en route, then you could get in trouble for accepting something beyond your scope or that you are not prepared to deal with. So make sure that happens before. Working with hospital staff, I bet none of you has ever met resistance with the staff before, right? It's a perfect world. They always welcome you there. So, but we got to keep that as much as possible, keep the positive relationship. I've been in the hospital before where it's gotten very heated, things like that, because we felt like we were overburdening them or bringing in people that they didn't deserve. But we got to realize that we're on the same team, what we're there for. So you're not going to know what all of the staff members are capable of, how the equipment's, all that's used. The biggest thing is know what that hospital is capable of. Know who your medical directors are or who you can contact. I know in some areas, the one you call for medical control is the destination you're going to. Other areas, there's a central location to where you might talk to for orders or advice. So just know where that is ahead of time. You don't want to be doctor shopping or hospital shopping, believe me, with a bad patient. That's something you do not want to be done. So it does work better if you have a good rapport between all the agencies. When you get to a hospital, hey, you introduce yourself, talk to the people, make sure you understand what their perspective is, and just try to explain your perspective to them. And a lot of times after you talk one-on-one with somebody, it does get to be better, other than it seems like a group, they have an audience, but it works so much better if you got a good working relationship between all the providers. Some of the other become familiar with who else might be in the area with similar roles, responsibilities. You're going to know that first responder that always shows up, what their level of training is, what they're able to do. They might not have a lot of training, but they're some of the best help you'd ever have in the world. I know myself, if I'm working a cardiac arrest, I would rather another paramedic not be there. I would rather me have an EMT or an advanced EMT. And I think once you get to advance your role a little bit, you'll see exactly what I'm talking about. But become familiar with other people's roles, responsibilities, what they can do for you. Some may be able to perform better functions than what you're able to do. I mean, for example, you don't want to go grab power lines. You don't want to mess with a chemical or some type of a fire hazard. The fire department, sir, you don't want to get into something you can't control. It can make it so much worse on everybody. But make sure you know what their functions are and when to call them out. Now, I'm not going to read all of them off to you one by one, but just some of the highlights. Maintain continuity of care by working with other health professionals. You started something and you handed it off to somebody to continue it and take it up another level. That's what that's about. And remember, now you'll be a higher level of care. So remember what somebody's given to you, and their understanding or their ability to do something for somebody may not be up to what you are. So don't cast judgment on that. Just understand, okay, they brought it this far. Now I'm going to take it. So, on scene, become a leader, be able to delegate. If you got to look around and say, hey, I'm the highest person here. It's on me. Be able to delegate and take control. And like I said earlier, people that want to downgrade or heckle the scene, I'll find some way to get them out of there. Emotional support. Hey, if you've never been on the other side of the stretcher where your family's being hauled or transported, then you'll be able to understand it a lot better. But just remember, you want to be an advocate for that patient. On-scene leader, like I said, gain patient access. You continue your professional development. Read articles, read journals. When you find those, when you're on post, look for things to read. Go after it and read it. Look for it. Be a good an example. I know we all have social media and things out there, but I have seen it come back to bite people. Like I was a supervisor in a location where this one girl says, "Hey, if you call us for the same thing over and over, I'm going to personally hit bumps." And in her profile, it had works for such and such. Well, guess how that went? So be professional. It's like, hey, would I want that person taking care of my family or something like that? Because it does go, what you do in this role spills over to a lot more people than what you think it would be. Just remember now that you'll be at a higher level of care. People are going to expect more of you, and they may ask a lot of questions to you that you're not familiar with. How do you handle that? So the big thing about this is maintain professionalism, knowledge, compassion, because more is going to be expected of you. I know I would expect more of you as an AEMT that got up in a truck than I would an EMR. So just remember that goes hand in hand with accepting this responsibility. So every patient is titled to some compassion and respect. What does that mean? Have you ever been a patient before, or have you ever had a family member that was a patient? How did you observe and watch the caretakers? I mean, whether it be in a hospital, whatever, you watched every move they make. I know it's been with my kid or my wife or somebody like that. I watch every move they make, and I want it done right. So remember, you're in that fishbowl type environment. So be able to say why. The people that call the ambulance for the most part are not having the best day of their life. Remember, you could, or somebody be very well in those shoes. Now, confidentiality. I've seen that get violated on Facebook, social media without people knowing it, saying, and we'll get into that HIPAA rule a little bit later, but remember that you're not supposed to talk about this to anybody other than the people that's involved in the call because it can get back. Uh, I got a call one time for a violation of a Privacy Act, and it was because a girl that was under supervision, his ex-wife showed up at the hospital. So how did you know? Well, so and so told their mom, and their mom called. So your mom might be your best friend, but hey, she's gonna, she gossiped. She told about it, and it caused a lot of problems, a lot of things going on. It ended up in child custody court and everything over all this. But anyway, that's how stuff like that can get out of hand. That's what we can't do. So that is the final slide on that. I'm going to take about a 5-minute break myself right quick, and then we'll go through chapter 2 and get through that. I'll try to pick up the speed a little bit quicker on it, but some of this stuff are just not a way to make it real exciting. Any comments, concerns, or questions about that first part? All right, Robert, I know there's a quiz at the end of each chapter. Will they do that on their own after this, or is it a part of this session? The quiz is at the end of it that's on the campus.
So the quizzes, yeah, there's a quiz for every chapter, and the date that's on those quizzes is tied to the night that we do the chapter.
Okay.
That being said, it's not that rigid. You can take the test whenever you want, whenever you feel confident in doing it. The only thing is you have to complete the module on time. So if the module has 10 chapters in it and you wait until the night before the module test is due, and then you have to take all 10 chapters and the module, that's just the way it is. But so I say that, don't not take the test, but
Yeah, okay.
you don't have to take the test the night that you have the lecture. You have some time for that.
Okay, I just want to make sure I didn't have to allow time for them on that tonight because I was going to go through this other one pretty quick. And
No, the tests are technically done on their own time.
okay, all right, this is what I wanted to make sure of. All right, guys, give me about 2 minutes. I got to get another Coke Zero, and I'll be right back. Okay, everybody, sorry about that. All right. Workforce safety and wellness. Now, it's not the easiest thing in the world to make this exciting. So I'm just going to go through it and hit the high points. I don't want to bore you with that, but I'll tell you the stuff you need to kind of look at later on. So my actual background is in occupational safety and health. So what might excite me about some of these things, of course, don't do anybody else. So there's more to it than just safety as far as PPE, things like that. But when we talk about workforce safety and wellness, let's just sum it up real quick to make it, what does it take to get me back home at night? What makes it want to, what can I do to keep from, becoming a statistic? And it all goes with you got the standard safety precautions that go over with the company, what we hear all the time, what we see on pictures on the wall, the PPE, stress management, death and dying, uh, prevention of response related injuries. That's kind of what we're going to look at real quick with this stuff. So, lifting and moving patients. Does anybody right now know anybody that's out of work because of a back injury? I know several. Being the formal safety guy for I've worked like for AMR and things like that. You'd get a lot of stuff as far as like twisted ankles or perhaps pulling a shoulder. But a lot of it was moving these patients. And the first thing I would ask is like, did you use a slide sheet? Well, no, I don't like those. Well, did you use a slide board? No, I didn't. Did you call for help? No, I didn't. And you see how those things could have been prevented by doing that. So, who's going to be, the thing that happens with that is most of EMS people work a lot of overtime because you don't get paid a lot for your regular hours. So you work a lot of overtime to make ends meet. Now imagine living on, let's say what your base rate is for 1 week at your regular job, and then take 44% of that, or imagine 66% of your salary. That's what workman's comp gives you. Yeah. So we need to worry about preventing these injuries. Disease transmission is a big one, right now going on that we've all heard of. We've always done the Hep B shots, to get the TB test, the flu shots, things like that. Those are ways to prevent disease transmission as far as immunizations go. But there's always, the PPE and other ways to deal with that protects you from that. Wellness principles, I'm not one to talk about on, getting out and doing a lot of exercise and things like that because, and believe it or not, exercise makes me tired. And I don't like being tired. But we do get out and walk. We work around the farm. Me and my wife do. Don't have kids anymore. They all are out and gone. But wellness principles, it has to do with eating and stuff like that too. So one of the biggest things, we have to take care of others, but we don't take good very care of ourselves at all. And I want to try to bring this to your awareness is personal neglect. I filled in an extra 12-hour shift the other night, and these other two crews were working 72 hours straight. I used to do that. I can't do it anymore. I'm just not. I can't. Personal neglect. What were they doing to themselves? Yeah, they like the income because it puts them making almost six figures by working those hours. However, uh, they smoke, way overweight, don't exercise, and they're not getting any sleep. When that tone goes off, I don't know about y'all, but it makes adrenaline about pump the top of my head off. So imagine coming from a sound sleep. It's just not good for you. And the stress that we face, you can probably talk to your partner or a coworker about things more so than you can your significant other or your closest person because they just don't get it. They just don't understand what we see and what we go through. So there's a lot of stress, and how do we manifest it? And if you stop and think about it, a lot of ways. I mean, how many of you have stopped doing things that you used to enjoy doing? Self-control. Man, we got to keep it together on the scene because everybody's looking at you to make a difference. People are praying for help, and then you show up. Guess what? That you're the help. Got to try to find a way to keep it together on scene because they're looking at you for guidance. If you lose it, guess what? those working below you are going to lose it as well, and then you've lost control of the scene. And once you lose it, it's hard to get back. Uh, Being aware of what you're feeling, the training, experience. Once you experience one thing, it might not necessarily make it easier for you. However, it might help you to address future endeavors of it, or to help someone that is less experienced in it. Some things are just bad. I mean, I've seen murdered kids before, and most murdered kids are murdered by people that know them. There's no easy way to get around that. But I have learned to channel that, and I went to counseling and stuff before over things like that. Why? Because it just kept invading my mind and my thoughts. And there's ways to help get around that. And I learned, it took me a long time to realize there's help for it. Get help for it. Don't try to be a superhero. Infectious diseases. The corona thing, we're still learning a lot about. An infectious disease, it's caused by organisms within your body. They, you get an infection like staph or something like that in your disease. It causes an infection. Now, you might get that, but it don't necessarily mean that it's a communicable disease. Infectious means it has an infectious source. Like, you're not going to spread a kidney infection to somebody else. You've got an infectious disease, but you're not going to spread that. Now, if you got the flu or corona or something like that, then it's infectious, but it's also communicable disease. It can spread person to person. There's some that can go from one species to another, like rabies. There's some other things that can be spread, but that's the difference between those two types of diseases, definitions. Risk to be, of course, reduced by immunization, protective techniques, hand washing, which is one of the most important. Hand sanitizers, I keep them in my ambulance, in my car. I keep them in my kit or my personal bag that I take on to the ambulance in case they don't have them on there, which a lot of times people, if they can't get them, they'll take those with them when they go home. They help reduce the risk of it. Immunizations. A lot of people are still out on the corona type vaccination. I've had shot 1, and I'm gonna get shot 2, and people are like, well, I don't understand, why do you do that? And it's like, well, for one thing, I'm in the back of a confined space with COVID positive patients, sometimes 2 to 3 hours, multiple times a shift. I got the PPE on. I think somebody in my case, I personally feel that risk, the benefit outweighs that risk in my case. Last week, I took a child that was positive for COVID, and his positive mother rode with us in the back. So here I am getting double barreled with it. So I think I got the PPE on. I just don't see where not getting a shot would benefit me, because I don't know. I don't want to bring it home to anybody. It's 1,000 wonders I hadn't got it yet. That's what my research and my experience and evidence for me is based on. Everybody will have to make that own decision. That's my little scoop on it. The proper cleaning of the ambulance. I clean an ambulance when I get on shift and when I get off, because I just don't trust the person before me done a good job. Things that you don't, they probably cleaned the stretcher, they probably cleaned the floor, but what about those little radio knobs that you got to touch, and that microphone, those oxygen controls, those cabinet doors? Did they really wipe those down after touching them, after touching somebody else? I don't know, but I'm going to go ahead and wash it or clean it and sanitize it. So that is something you need to think about. Does everybody do that? Did they drive the ambulance with bloody hands or something even before all this? I've seen people pick their nose and then put it back on the steering wheel of the ambulance. Oh crap, no, don't. I'm cleaning the steering wheel before I drive it. So that's just the way that that does. So as far as discretion, you must inform other healthcare workers who may come in contact with a patient with a potential risk, but you got to be discretion about it. You get to the hospital, tell them, hey, this patient is positive for this. You don't tell the whole world, you tell the person that's going to be taking care of it. You don't want to give this sensitive patient information over the radio or something like that. You want to do a complete history for the receiving facility during the transfer of care if you're able to. You might not always be able to. And include pertinent history in your written documentation if at all possible. In your summary, depending on what method you use to chart, I'll say something like, hey, this patient was diagnosed with COVID 2 weeks ago, or a patient had TB a month ago, something like that. But you want to be able to document that in the report, what you know about it, because a lot of these communicable diseases is reportable. All contagious diseases are infectious. Remember that I told you earlier, but not all infectious diseases are contagious. So it's kind of like, there's an example that I use a lot. It's like all bourbons are whiskeys, but not all whiskeys are bourbons, kind of like that. So infectious disease is caused by an infection, and a pathogen is a germ, microorganism that's capable of causing disease in a host. So remember that not all infectious diseases are contagious, but all contagious diseases are infectious. It's kind of confusing. It's one of these things you might have to sit back and look at a little bit. But the ways that these are committed: direct contact. If you put your hand in somebody's blood or somebody's body fluids, if you touch it directly, that is direct contact. You come in contact with the source unprotected one way or another, whether it be in your eyes, your nose, your mouth, a cut. Indirect is something else gave it to you. Hey, it was a cut piece of glass, maybe. It was a needle stick. It went. I sat down on a needle once and it went in the back of my leg in the truck. Yeah, no, and that was an unknown source. Bloodborne pathogens are microorganisms that are spread in the human blood. It can cause disease. And some of those are like hepatitis, HIV. They're transmitted in that way, direct contact. Airborne could be sneezing. These vapors stay in the air for quite a bit. Foodborne transmissions, eating food, getting flu poison. Vector-borne transmissions like fleas. And remember the plague, the bubonic plague, was not spread from rats, but it was the fleas that came from the rats that actually had that disease. So or a mosquito can transmit an infection to you as well. Airborne transmission, again, it's droplets, kind of like dust that stays in the air. This is how mainly the common cold is spread. COVID, they're still trying to decide exactly which way that goes. And the foodborne transmissions. Christmas Eve a couple years ago, ate some bad crab, man. I tell you what, E. coli is not fun. And several people, I think over 150 people that day got infected at this one place. So germs are bad. They can kill you. I've always been a germaphobe. I've had spinal meningitis, bacterial meningitis years ago, had to learn to walk again and everything like that. So, and I don't know how I got it. So I've always been kind of a germaphobe. Where these routes of transmission, like sneezing, hey, you see people sneeze all the time and it goes everywhere. That's why I'm a big advocate of wiping down the cab of the ambulance, because people sit in both chairs and they probably sneeze, and where does it go? It's there. I've just always been a germaphobe like that. So they want you to sneeze into your elbow is the best way. If you sneeze inside of a mask, if you had that happen yet, it kind of blows back in your face, which is a lot of fun. So bloodborne pathogen training and OSHA requirements. These patients are having diseases. We talk about contact, full body contact, droplet contact, things like that we learned all the time during the orientation or in annual training. And it is required by OSHA, because a big part of your safety is on you. You know, who's most responsible for your safety, and it is going to fall back on you. And that's why they train this, because a protection plan or a safety plan requires participation. There is standard precautions out there to prevent workers from coming into these infections. And one thing is universal precautions. Treat everybody like they got something. That way you're covered. You know, I've had people tell me, oh, you don't need that, you don't need this. But gloves, gowns, masks. I carry a gown in my BDU left pocket. I carry a gown right there because not only is it for the COVID or whatever, but I've always carried it because I don't want, if I pick up somebody that's got diarrhea on them or something like that all over them, I'm going to put that on and protect myself because I don't want somebody else's goo on me. Mask, eye protection. In 1 week, I had 3 medics that had somebody spit in their eyes. And then they asked me, hey, do we need to wear safety glasses on every call? I'm like, I don't know, do you? I mean, just look at what happened to you. So that's something to think about. And that, you shouldn't have to be told, well, you need to wear it because of this. It's like, hey, here's what's happening. How can I prevent this? And you are ultimately responsible for your safety when it comes down to it because nobody cares about you more than you do. And there should be a designated safety officer within each agency to contact if you need to report something like that. Proper hand hygiene, it can't be overemphasized. I know we hear it a lot. We hear it all the time, but wash your hands as much as you can. If that's not available, use your sanitizers, but hey, I use both if I can. Glove is the minimum standard, should be used on everybody. Change gloves in between patients. Also, big pet peeve of mine is to see a partner or somebody leave the scene and drive the ambulance to the hospital with the gloves on. That needs to be dealt with right away. Explain to them, hey, here's what you're doing. The next time they do it, it's like, okay, have an even deeper conversation with them. That's why I always clean and sanitize the steering wheel and all that stuff before I get in the truck, because somebody's going to do this, whether they mean to or not, or they're just not knowing, that they're going to do this. So the eye protection, the safety glasses. You see the guy on the bottom of that picture right there. I've had that happen before. I've had stuff blown on my glasses before, and the prescription eyeglasses alone is not adequate. Although a lot of people do that, I've been guilty of it using just that as well. I've just been fortunate, but that's not a very good protection means. You need to put the goggles or the glasses over them. They also have some pretty stylish safety glasses available now. That I have to use prescription eyeglasses all the time. So, and I've got, I had a pair made, the safety glasses that are prescription to me, and they don't look like the big horn rim type glasses either. So that's something you might need to think about if you require glasses. And contacts, you don't want nothing getting behind those because once it does, then you are contaminated. You got to take your contact out. You got to throw it away because it's not good anymore. So that's something you need to really think about as far as protecting your eyes. Gowns, they a bad trauma scene, something like that you know of. You don't always have time to put that on. Especially like on trauma, because sometimes you don't know how bad it is till you get out. Sometimes when you have able to prepare for it, that's fine. But sometimes these can actually be a greater risk. The risk of wearing them sometimes might be greater than a benefit. Like if you're going into something where they got rotating machinery or something can get caught or snagged on and snag you up in it. That's something you definitely want to be aware of because they're not always appropriate. You got to stop and think, well, if I wear these, then this might happen. So the masks and respirators, the surgical mask should be used all the time in this environment that we're in. Patients should receive a surgical mask. N95s are only good for filtering things that are going in, not coming out. So if you might have a COVID patient and you're like, oh, I'll put a HEPA mask on them or an N95. No, it doesn't keep it from coming out. So they need a surgical mask and you need to wear the N95 or the HEPA mask, because like I said, it only filters coming in, not going out. So that barrier devices, mouth to mouth, you want to protect yourself from the patient, any type of fluids or any type of direct contact, but that's what these are for. They're only supposed to be used for one time and not reused. Sharps containers, proper disposal of sharps. This needs to be easily within reach of you, somewhere you can get to real quick. I haven't had to drop them on the floor before just because of practicality, but I've always told my partner, hey, and these were the type of catheters that drew all the way back up and clicked to where they protected themselves. However, I've got one by my jump seat and I've got one on the bench seat right behind me that that I need to put stuff in, because I've sat on a dirty needle before, and I had to take like 2 months of these antivirals and stuff like that to protect in case of HIV or anything. Which, then 6 months later you get another test and it was all negative. But that medicine will make you so sick. It is. I mean, the medicine is very, very challenging to your body. So dispose those in a proper place. You don't want to. You're going to be tempted to recap a needle. You're going to be tempted to break them, but don't do that because it can pop back in you. Capping a needle can very easily cause yourself to get stuck by it. You just simply do not redo that. You throw them away as soon as you use them, as much as possible. The employer, required by law, is supposed to provide you a workplace that's free of hazard or harm as much as possible. However, there's no way they can cover everything. So, it's part of your job to protect yourself. Tools of the trade. Overall, they say that your infectious risk is not very high compared to in the whole scheme of things. But the jury's still out on a lot of that. I've known 4 paramedics personally that I've sat in a truck with that have now died due to COVID, and one of our pilots. So it's like Russian roulette on how bad this is going to affect you. The employer they're given OSHA and CDC guidelines, and they should have a plan in place to cover that. They should have an infection control officer to cover those. But it doesn't hurt for anybody can go on the OSHA.gov website, which is a pretty neat website. It's got all kind of subcategories. It shows the protection, your rights, what you should do, what's your responsibility, because there again, nobody's going to protect you or cares about your safety as much as you do. The infection control should be part of your daily routine. Clean the ambulance like we talked after every run. The straps, a lot of time are neglected, but think about it. Hey, your mom or your grandmother or somebody could be the very next patient that goes on there. Are those straps clean enough to go on them? Even though, I've got a pretty decent partner now, they clean the straps religiously. I'm still going to put a protective covering between there, sheets or blankets or something like that. The ambulance should be done at the hospital when possible, because they got like red bags and stuff in there to dispose of. You really shouldn't be hauling them around. That's really not the correct thing to do, although we do have circumstances that are unique to our own situations. So the infection control plan should extend to like determination of an exposure. Now, technically, if you get blood on your arm and there's no cuts or anything like that, that's considered contaminated. If you have a cut on your skin or it gets in your eye or your mouth, that's considered an exposure. That's according to like the OSHA guidelines and how they divide that up in. Hepatitis B vaccine, education and training, PPE. You're supposed to be provided with PPE through no cost to your own. That's supposed to be provided for you. The skin test every year, they're getting away from doing that every year because they're finding out that especially the blood test, or once you've tested positive, they shouldn't test you again. You just should have to do a questionnaire. Occasionally, every 3 years or so, they may require a chest x-ray, but they're kind of getting away from doing it every year type thing. Record keeping, report. If you have an exposure, report that to somebody. Keep a copy of the report for yourself, because you might get stuck today, nothing comes of it, in 10 years come down with something. They have to keep these records by law for 30 years after you leave their employment. So report it. No matter how insignificant you may think that it is, you need to report any incident of exposure or suspected exposure. And because something could develop later on it. And I've seen where people fail to report something and it come back to bite them in the butt later. So, and learn your areas of disclosure about medical waste, whether you have an agreement with the hospital or if you have an agreement with the company or something like that, know what you're supposed to do with it. Even if germs reach you, you might not be at risk for infection. If you got immunity for it, like a lot of childhood vaccinations we may have gotten, or if you've had like the mumps before, you should be immune to it from getting it later on. Or chicken pox is really only a partial, because you can still develop shingles, which is the same germ. And if you've had chicken pox, that germ, it stays in your body forever. It never goes away. But under times of stress, it may come back as a type of shingles or something like that. So there's some diseases that we can't be immune from. Like, for example, HIV. You can't be immune from that. AIDS, that's something that you're still will always be able to catch. It's always a possibility. And what's bad is this COVID stuff is kind of have caused other people to get kind of complacent and get away from these other diseases that are still out there and still very deadly. The best way we can do this, I know there's a lot of undecided on the corona thing right now, but the gut immunizations out there, the TB test yearly, like I said, they're not doing it every year now. They've got a questionnaire that you should follow: night sweats, cough, fever, late weight loss, things like that you should need to be aware of. And you're not going to know which patients have these diseases a lot of times. I had no clue how I got meningitis. I thought I hurt my back and it started getting up into my head. I also test positive for the TB test. That means sometime in my career, I've come in contact with it, have no clue. I had to take the medication for a year. And that has resulted to me, it's always going to live, that those antibodies are always going to be in my body, because I never know who had it. So always be aware of this still could be happening somewhere. If you got any suspicion, put that mask on. What have you got to lose for it other than protect yourself? But keep that mask on when something like that happens. Post-exposure management, a lot of time you need to go right then to get treatment, or as soon as you can. You need to, a lot of times, call I don't know where we work, you call your supervisor and they'll do a blood work kit, a lab kit right there in the emergency room, because they need to get a baseline level on your antibodies, on your exposure level, and they'll probably give you the option right then if you want to try some type of prophylactic therapy. When it talks about you being involved in prevention, like you're a role model. Going to high schools, giving lectures, a lot of time is heart disease. And sometimes patients are going to ask you, well, what can I do to prevent this? And some of these illnesses and stuff listed here, you may be able to talk about it, like stroke, how to recognize a stroke, diabetes, what's the difference between influenza and pneumonia? And some people might ask you suicide. How do we know when somebody's possibly going to be thinking about suicide? That's not something that people like to talk about, but that's when you talks about you being part of a prevention program, that's what it's talking about. Safety personnel, we talked about earlier that scene awareness actually starts from the time you get the call. So in protecting yourself, seatbelts, wear your seatbelts, your shoulder harnesses, be sure that you're restrained right, because I did a case study about 5 years ago, and at that time there was whoever was driving the ambulance, whether it be EMT or paramedic, but there were 5 of them in prison, because that they had wrecked and killed their partners, and it was vehicular homicide, what they ruled it as. So wear seatbelts, shoulder harness, because these ambulances, you can't get killed in that. You're not immune from it. A lot of people don't pay attention to you. You're big, you can't stop. Start getting some of your PPE on that you can right then. Your safety glasses are easy to forget when you jump out of the scene real quick, but if you go ahead and put them on, and your PPE, like your gloves and stuff like that, clean gloves going to a scene is different than having dirty gloves on after a scene. You want to make sure that you're seen. I think in Alabama last year, a couple of years ago, there was some people killed at the scene of an accident site because people didn't see them or not paying attention. Hopefully the fire department or law enforcement, somebody can put up some type of warning devices for you if possible, or have other vehicles there to block it. But if not, you may have to park your ambulance somewhere. A good place, if you're the only one on scene, is to shield yourself from another oncoming vehicle, is to put your ambulance between the car and oncoming traffic. That's sometimes what you might have to do. The hazardous materials, To a lot of people, that's boring and stuff like that. However, these things can, they can get you killed. I've been on scenes before to where an 18-wheeler was upside down and it was steaming or some type of thing, listening to it. And the police officer didn't want us to leave. We're like, we grab our people and run, or we just wouldn't come in. I was on a sprint truck once and on I-10, and they said there was an 18-wheeler going down, leaking something out of the back, and the volunteer fire department, and they wanted me to follow as well. Let's follow him and try to get him pulled over. No, I'm not riding behind somebody that's leaking crap all over the front of my truck. I mean, that's stupid. And they had no idea what it was. So don't enter an area unless it's safe. Don't enter an area unless it's safe. So the DOT is your should be in all the vehicles to help you assist with find out what they are. The vehicle collisions, some of these things are, I've known some people that's got killed in these wrecks, people on the side of the road, medics that's got run over, pedestrians that's got run over, and they you don't really think you're moving sometimes, but you forget about some of these hazards as around. Electricity, grabbing somebody off of a source that's not protected or isolated, can get you killed. Don't go into a car with a down power line or try to remove it. There's somebody else there that needs to be trained to do that because it can kill you. Lightning on golf courses, playgrounds. I've seen some lightning strikes before, and some people did okay and others not so great at all. The thunderstorm doesn't seem to have to be real close to you for it to happen. Just for the right type of ground discharges, as far as air discharges are available, and it can hurt you anytime. You don't need to be in a wet area, not even in a ditch or any place that it's wet, because that electricity will follow you. It can follow wet ropes. It can get trees. It has so the best way to do it is try to avoid lightning scenarios at all. However, it's not possible when we're out on a golf course or something like that. Some places will look, hey, the storm's too bad, I'm just not going in there. Fire hazards. We don't want to be that guy that runs up into a scene or a house fire and something happens or you can't get out. There's people that's trained to do that. Probably what will happen before you actually get into a fire, the fire itself would be some type of bad gases. Carbon monoxide, you can't smell it, you can't taste it. It's really responsible for most of the fire deaths. I've seen a lot of people that died in a house fire that weren't really burned, but they had died, they'd suffocated because of the CO2, or I'm sorry, CO. The cyanide is another one that can be start from burning plastics like mattresses, plastics, toys, other material can release cyanide, and it will actually prevent your cells from using oxygen. They may have an oxygen source, however, with the cyanide, it's completely blocking it, and it will not allow them to breathe. They actually suffocate to death with it. The other scene hazards that can happen, like violence. We see a lot of violence nowadays. It's starting to happen. We see these stories all the time where EMS is becoming an easy target because they probably know you don't have guns and that you carry drugs. That could be one reason they get there. So another thing that can happen is domestic disputes. One of the worst calls you can go to is a domestic where there's been a big family fight. Some of the most violent calls I've been were domestic issues with family members. Once with I had 5 shooting victims in a house, all done by a family member, and so those could get bad in a hurry. If you see if you're in a domestic dispute and something's going on, you need to try to get away from that as much as possible. Either get them away or leave if you have to. If you can get the patient to cooperate, I've actually made up a scenario before to get a patient to go to the hospital to get them away, and found out that they were being abused and stuff. So that's not an accusation you want to make in the house, but that was something that I was able to say why I did, but it got away from it. Crime scenes. Sometimes we got to get in, treat the patient, get out without disturbing a lot of stuff. It's always not possible, but they work with law enforcement. I've actually had law enforcement people say, hey, I got to move this, and they'll take a picture of it. And if I had to get to the patient, it's the only way I can get to the patient. When several agencies respond, it's important to know who's in command. A lot of times there'll be some conflict, like this is our area, this is yours, or something like that. So we need to establish who's in command and who can be responsible for that, because definitely don't need any chaos. Behavioral emergencies, these are a lot of time they don't have a clear physical cause, but these patients can be violent, they can be hallucinating, they can be suicidal, they can be quiet and docile until you get them in the back of the truck and then start to come alive on you. So most of them you're pretty much willing to work with. Spice patients can be bizarre. You're not sure how they're going to act. LSD patients, which there are starting to see some of that come back. Just remember, you don't want to try to do anything to provoke it, but there again, you want to be able to protect yourself too. You don't want to stand between them and an escape route. Sometimes if they're that violent, they may hurt you. So I personally don't like to get in fights with people or stuff like that. I have had to defend myself before, but there's no other way around it. So just be aware of this. And if they're too violent to go in a police car or something like that, they probably don't need to be in the back with you. I've had patients kick the windows out of police cars and cut their feet, and they call me and said, "Hey, we need you." I said, "No, that's not happening. They're too violent for you. They're going to be too violent for me." That's protecting myself. So we're all about clothing and turnout gear. I'm not going to bore you with that, but remember, layered clothing is best. Sometimes long johns is good for like weather that we've been having. But I know with me, too much clothing sometimes can become cumbersome. In the fire service, of course, helmets. Some industrial areas you go into are going to require helmets for you go into because they got falling objects. Boots. It's good to have something with a good steel toe and it supports your ankle. Because you twist that, you go out to work for a while. It's not going to do you any good. Eye protection we talked about earlier, but of course the goggles are the best. But I would look into if you got to wear prescription glasses, or even if you don't, they got some stylish safety glasses out there that are approved for this. They're wrap around. They keep stuff out of your eyes. The skin protection, sunscreen, if you're going to be out like in the beaches or work in special areas, and the body armor. There's some places I know AMR is actually making. I'd seen where in their uniform orders where they can actually order these now and be part of their uniform. A lot of other places also have these available for their people as well. I'm kind of like, man, it's a shame that it's come to that, but it is. Stress in this job is, don't be afraid to reach out for help with somebody. And a lot of this stress sometimes is happening without you even realizing it. Like first, you get an alarm response to stress, whether it be good or bad. It causes you to act. Or do you act or should you refrain? And there's a condition, recovery or exhaustion is what it can progress to if it's not dealt with or if it keeps being prolonged. So we're going to look at the stress things a little bit. With stress, adrenaline is released. And this is what the causes are. You get your respirations are going to go up, your heart rate's going to go up. These physiological, it's getting late, responses are because of adrenaline and stuff is released in your body. Your increased blood pressure, your cool, clammy skin. And some of this it's good if you're exercising, or it's bad if you have long shift work, long hours. When you're staying up and not going to sleep, your body's releasing adrenaline to keep you up. Even the fact of being up excess hours is a stress response, and it's not good for you. It's hard on your heart. It's hard on your vessels. It's going to cause your blood pressure to go up, and then your body's going to get to where it doesn't pay any attention to this. An acute is something that happens during the situation, and that's not really bad. Hey, child got hit by a car. It's stressful. Okay, it's going to cause you to work and be focused. It does have that part, but sometimes stress reactions are delayed. It may happen later, like you did the call, you got through it, and now you're shaking and stuff. You're shaking and upset, or sometimes it don't bother you right away and it builds up, like prolonged. You're unable to shake it off. You're unable to get past this. You this adrenaline is still going in your body, and you find ways to dull it. For example, alcoholism or drugs, things like that. People get depressed, but do they call for help for it? Very rarely do they. A lot of times they don't. So things that can really set you off initially is the MCIs, traumatic death to a child, serious injury. I've found myself before the adrenaline rising, I can feel my heart beating. Stuff gets up, and that's a normal response. But you got to find. We talked about the self-control earlier. Because hey, I'm the only one that can help this child. I got to do what I got to do, and I'll fall apart later. Death or serious injury of a coworker in the line of duty. And I've seen that happen. I've seen it happen to a few times to some people, and that does bother you. It's staggering. It makes you feel like, man, it makes you feel vulnerable, and but a lot of people will just go on and they'll shelter this. They'll put it in a place that it's hard for them to recover. So, and I usually shared this at this part, but several years ago, I'd worked 3 family murders in about a 3-month period, and my coworkers actually went to my boss and said, "Hey, man, you're just not himself," and all that kind of stuff. And just about all these right here were happening, and I'd have this dream to where that I'd go to a rodeo arena and people were just shooting people when they run out of shoots and stuff. And I went to talk to somebody about that, and they said it was just me trying to wrap my brain around what had happened, what I'd seen. I was trying to make sense of it and see how somebody can go to a loving nurturer to a killer. But the way they explained it to me, it made me realize, oh crap, I'm not going crazy. I'm just a normal human being dealing with some very abnormal situations. So that really can help. And I thought, man, I'm cracking up, but it wasn't that at all. It was just me being normal. So, but look at some of these signs here: difficulty sleeping, or increased sleeping, or nightmares. You're trying to hide it. Loss of appetite, isolation. And I've seen this in some of my coworkers. And you know what? I counted when I was reviewing this lecture earlier. I counted six people that I've been partners with through the years that have killed themselves, and not all of them showed signs or anything like that. Some of them did it so planned out that it was scary. Going to another town to where his coworkers wouldn't be the one to respond, or one guy wanted everybody to find him, and he actually started a bunch of IVs on himself and bled to death. I mean, so you really, watch this in somebody. Don't be afraid to speak up and say something to your boss. I mean, I wish I had, but it's just something that I share now in these classes to show how real that could be. So some of the things you might can do it: change work hours or cut back on overtime. Man, I know people that work 168, 200 hours or more every pay period. And I'm like, man, you're not, yeah, I'm making $100,000 a year, but dude, you're going to be dead. I mean, it's just, to me, I don't see how it's worth it. It took me a lot of years to realize I didn't need to do that anymore. Talk about your feelings, seek help if needed, just kind of like I've described to you. So, it talked about adopt a relaxed philosophical outlook. I'm still trying to figure out how to do that. And I did come to the conclusion that most of the people that write those books have never been paramedics. So maybe some of y'all or somebody needs to step up and write a book like that. So they say it's usually not the event that does it, but usually the person's reaction to it. And that's something we got to work on every day. CISM meetings, critical incident stress management is a good thing. They'll start up for a while, then they'll drop off. They need to be formal, and they need to be kind of guided, because you don't want a bunch of war stories or something like that be told. But they do need to have that, and it does need to involve every agency that was involved in this, because I'm a strong believer in it, but you just don't see much support for it anymore. Burnout, hey, I've been there, and I've come back, but I've been there. And it's typically exposure. Expose yourself to so much of this without finding time to be a person, something other than an EMS worker. So, chronic fatigue, irritability, lack of desire to report for work, man, you just don't care. Overwhelmed, either overeating or not eating enough drugs and alcohol, not being empathetic toward people anymore, seeing patients as the enemy. But you got to find time to be a person away from this. You got to de-expose yourself so much. So, hey, I need you to work another 24 tomorrow. Well, I've been on 2 days already. Well, no, I'm sorry, I can't. I just can't. There used to be a phrase years ago. I had heard it a long time. I think they stopped doing it because it wasn't politically correct anymore on the side of HIV, but they called it AIDS, ambulance-induced divorce syndrome, because so many people went through burnout and they wouldn't speak up. There weren't a lot of programs available for them, but it's time we kind of stand back and take care of ourselves a little better. So debrief after tough calls. What does that mean? Hey, even if it's just talking to your partner or a supervisor or somebody, sometimes you need to debrief after those calls and don't let it build up. If you find somebody that's unapproachable or know somebody's unapproachable about it, then just simply talk to somebody else. But there are people out there that be willing to help you out with that. So you got to realize, hey, not everything is your fault. Everybody's overwhelmed right now. And the suicide thing, if anybody ever expresses that to you or talks about it or just acts different, hey, I know it might become an awkward conversation, but I know 6 times I never said anything. Eat right. Now we know we all eat salads and stuff like that on post. The fat-free stuff, all of the hope. We know we all eat all the organic stuff. We don't ever sit back and fill up on Cheetos and a Coke on post. Water, a lot of times headaches, feeling down, feeling tired, because sometimes it can be just dehydration. Water, I don't drink a lot of water at work. I drink a lot of coffee and I hate to admit it, but a lot of those energy drinks. So those are not good for us. Here's what we all should be doing all the time. But if I'm doing that, I hate to admit it, but just look behind me and you're going to see a pit bull or something back there. But exercise does help the body and the mind. We need to try to make it. We work around the farm here. Me and my wife, we raise these sheep, exotic sheep, stuff like that. So we do a lot of work around here, better than what we used to do. But you need to find some type of an outlet. If you don't smoke, don't start. Sleep. My gosh, I envy people that can sleep good. Sometimes it's not the length of time that you sleep, but quality. Sometimes a good, hard 2.5, 3 hours sleep after you've been up all day is better than a 8-hour stint of tossing and turning. So you need to make time for yourself to sleep. Allow yourself to sleep. Don't feel guilty about it. Finding a balance between work and family, that's something that you got to get under control because, man, I know a lot of people that's going through life by themselves now, or things have happened that when they look back on it, it's what did they do? What they sacrificed themselves to this industry. And you don't have to do that. It's fun. You can do it. You can do it very productively, but you got to allow yourself to be a human being. You got to something other than somebody else's hero. You've got to let that happen to yourself. So this field attracts a lot of diversity. You got people coming from all races, cultures, ethnic societies, and a lot of them bring different things to this field. So, embrace that. It's what you can learn from other people. In some of the areas you go to, they may be culturally different than what you're expecting. There's types of practices that, like I went to a call here not too long ago, and it was for weakness and dehydration, and the patient was on I think it was for Ramadan, they was on like a 40-day fast, and they didn't want anything done. They just wanted to go to the hospital. And, it's like, okay, I can easily correct this with a liter of saline or D5. But there again, they knew what they were doing, and they knew it's a cultural difference that, you got to embrace and realize everything's not like yours. Not all people, like on the helicopter, we could give blood on scenes, but not all people are willing to accept blood. So that's something that you got to respect and appreciate. So, don't be afraid to talk with each other. If someone asks you a question, hey, why do you do this, or why have you done things this way? Don't become offended by it. It's a way of learning, and it helps people to understand. And it's so much easier to help somebody or to understand somebody if you see their perspective. Stephen Covey said, "Before being understood, seek first to be seek first to understand before trying to be understood." That carries a lot of value to it. Sexual harassment. Man, that's it's a hot topic nowadays. EMS people, I've seen firehouse police. Sometimes they do cut up and carry on a lot that would be very offensive to some other people. But bear in mind that any unwelcome or verbal physical contact or an overheard conversation can be transpired as sexual harassment, and the perceptions, not intent, matter. So, quid pro quo, that's a phrase you'll hear a lot through orientations and things like that. And that's simply sexual favors for something. I'll do this if you do that. That is very inappropriate. And jokes, touching, requests for date, talking about body parts, all that can be considered unwelcome events. All right. Substance abuse. We do have a lot of substance abuse in this field. We do periodic drug tests, but I've seen where medics and stuff have taken drugs from the NARC cabinet, drug counts not coming up, and people, getting involved in this. And once they do get involved in it, it's hard for them to turn around. I've seen people from very high positions in certain regional hospitals lose their whole lifestyle because of substance abuse. So if you have a problem or know someone that has one, if you speak up about it, say, hey, I got a problem, they really work with you a lot better than they do if they just catch you in a random audit or an accident. Death and dying. You're going to face it in this field. You're going to see the different stages of it, and someone else that may be having it, like they get angry, they deny. There's like 6 stages that they go through. I encourage you to read that in your text because I want to get into it real deep here. But sometimes death is sudden. Sometimes it comes after a long illness and can be expected. But when the moment actually comes, it's going to be hard for that family or that loved one. So that might be where you're kind of in there as emotional support. Be careful though about what you say to some people. Everybody might not believe like you. For instance, your religious beliefs may very well be different than somebody else's. But I had a man about to attack a first responder one time because his son had died. I pronounced his son dead. He'd been dead for hours. And the first responder said, well, he's in a better place. Well, that gentleman happened to be very mad at God at that point for allowing his son to die. And so that wasn't, even though the guy really meant well by it, that was not the appropriate thing to say in that situation. So just bear in mind that everybody may not feel like you do. And you recognize their pain, address it, don't ignore it. But unless they ask you, I would just, and if it's your advice that you're imposing on somebody, that's when I would stop and think about it. Maybe they're not that kind of person. Look around their house. If you see Christian pictures or something like that, or pictures of a religion or some type of a faith, maybe it might be okay to say something. But just be wary that they may not agree with your view at that time. And if they don't, and just apologize, just apologize and just be honest with it. The family members, one of the most horrible sounds I've ever heard is family members in the background once you pronounce somebody or somebody dies. That is horrible. So try to get in touch. If they need you to call somebody or get in touch with somebody, then ask them to do that. How can you help them? A lot of times the dying patient handles it better than what the family does. So if you get someone that's, I've had people tell me, look, I know I'm dying. I don't want you nothing for me. Just let me go. I've had that happen before. the family is begging for you to do something. And so that's a tough situation to be in. I've had to call med control on things like that before, but just remember that these are tough situations. All of it's not written in a book right here. So just try to be empathetic that this is probably the most significant moment in these people's lives. Death of a child, it doesn't get easy. It's never easy. I've seen a lot of them, and it's never easy. And the pain that the family is going through, you can feel that. Now, I've seen people transport, say like a SIDS death or a dead baby that was already rigor mortis and mottled and changing colors, that they would transport that baby and code it for the sake of the family. You got to be professional and objective in that category, because that baby's dead, they're dead. It's not going to be any easier, but you don't code a dead body for the sake of the family. That's just not something that you do. Now, if it's close or if there's any doubt at all, by all means do, but I'm talking somebody in that stage of death. That's not something that you should do for the family, because that's when your judgment becomes clouded, fall back on your training. So what do you do with people with rigor mortis? You pronounce them. So just remember, when your judgment's clouded, fall back on your training. So we're winding down here, guys. I know the clock's ticking. Introduce yourself. Try to find out the patient's name, because it really changes something. I've done it. Get to the hospital. What's their name? Oh, hold on a second. That's kind of find out what their name is if at all possible. Let them know what you're doing. Try not to. It talked about sad and grim comments. I had a paramedic student with me one day. I had a guy having a STEMI, and I showed her the EKG, and you can see the big time ST elevations, and we all know what we call them, fireman's hats, or the other words. The patient's like, "Hey, what is that?" She said, "This is what we call tombstones." I mean, the rest of the call was very difficult after that, because the poor guy, you got to watch what you say to patients sometimes. Like I said, their understanding is not like yours at all. Allow them to express themselves, talk to them, ask their concerns. Maybe you might be able to explain something to them. "I don't want no IV." "Well, sir, I need to give you one in case something happens en route. We'll have a tool to address this." Religious and customs we talked about. Remember that not everybody has your perspective, and you got to be able to appreciate that. Be honest. "Hey, is that going to hurt?" "Yeah, it's going to hurt." But so be honest with that. There's always a possible refusal of care. Sometimes these can get you in trouble, but be sure they know what they're refusing. If there's any question about it, your agency might tell that you got to call med control, but if they're competent and said, "Hey, leave me alone," it don't matter if they got an arrow through their head. If they're awake, alert, and oriented, in their right mind, "Hey, leave me alone. I don't want your help," then your hands are really tied. If they have an altered level of consciousness or a minor, then it's a different situation. So know what your policy is on that. But always document, "Hey, I told this man, like the other night, hey, this EKG is not a substitute for evaluation by a physician, and you could still be having a heart attack that doesn't show up, and refusal of not going to the hospital could cause you to die. Do you understand?" "Yeah, I'm not going. I'll get COVID. We'll sign right here." That's all you can do. So, med control should be a good resource for you to call. Sometimes you don't get a lot of cooperation, but remember, something can build. Like, for example, a head injury might not be obvious at first. Minor signs may be early indicators of something bad. So they got a bump on their head, they take Coumadin, they're acting okay, I would still make them go to the hospital. That's a minor sign at first, but that person might not wake up tomorrow due to an inter-facility bleed. So that is the end of tonight's 2 chapters. You've got the quizzes that you got to do, like he said, and on campus, I think he uploaded the class schedule, what's to be expected, and the items that you can read ahead on. Now, do I have any comments, questions, or concerns about tonight's information? All right, Robert, you got anything to add?
Sorry, I'm not used to the student layout on this thing. I was trying to find the unmute button. No. So, all right, I do need this for everybody in the class, just because of the way that Louisiana conducts its certifications. We have to get you guys registered as Louisiana EMTs. We do foot the bill for that, but I need you to actually get into the Louisiana Bureau of EMS portal. I sent out a walkthrough for that. Make sure y'all get that done as soon as possible, because we need it. We need that to be done sooner than later, in case something gets held up and we start fighting with the state over getting out-of-state people their certifications. Other than that, everything else we've got time to work with. That should be front and center. If you have any problems, let me know. If I can't fix it, we'll get you in touch with John Cavell. He's the director of EMS education at the state. And that's just to make sure, because I don't want to get through the class and then people not be able to get their certs. That would suck. So if you have any issues with that, just let me know.
All right, and I need to assign a PIN number for tonight's class, right?
Correct. Yeah, 5 digits or whatever you want to do is fine.
Okay.
And just, well, I mean, I'm in the class too, so I'll know the PIN.
Okay. What I'm going to do is I'm just going to let's just do like the date for right now. Let's see, 10421. How's that? Everybody got that? 10421.
So in case, I mean, I know some of you guys have been through our course before or have seen the website. On your way into this class, the last page you were at, where you had the green button to click and come into the advanced class, there's a form on the right that says attendance. Every night after class, that's where you're going to fill it out. The PIN number that Lynn gives us, you're going to use that each time we have a class, so that if I ever have to go and run an attendance report for the state or for the registry, they want to say who was in this class, I can search that PIN, and then every one of us that was in the class that logged our attendance will be in the list. So that's the easiest way for me to keep attendance with people being not in the same room, like it would be in a traditional class.
Okay. All right. Robert, I'm going to give you
Robert,
in just a minute. Rocky?
yes, Robert, the form you were discussing, as soon as I signed in, I actually filled that form out and it used my zip code for the PIN number. Do I need to do anything different, or?
Yeah, do it again. So the attendance form you'll do at the end of the class, because the PIN that Lynn just gave us, that's what you're going to put in that spot. That's for me to track who's in what classes, so that if we ever get audited, I can pull up and say, yes, the student was in these classes, or this many students were in this particular class, that kind of thing. So if there comes a night where you miss a class and you don't catch it live, that's fine. We record it, so the recording picked up where Lynn said what the PIN was, which is 10421, in case you didn't get it. Sorry, I know that my microphone's picking up my son's cartoons in the back.
All right. Well, I appreciate everybody tuning in tonight. My email should be on there if anybody needs me to send me an email or anything like that. But that's all I have for tonight, and I'll see everybody Wednesday at 6 p.m.
Sounds great. Appreciate it, man. I'll text you in a little bit.
Okay, man. Thanks a lot. All right. Good night, everybody.
Thanks, Lynn.
You're welcome.